take any actions they'll be on. Does that sound good to you?
That does. That sounds great. Connie's
Okay.
telling me to speak slower to help.
Great. So I am going to call this meeting to order. Here's that gavel. Hope you got that, Connie. That one's for you.
I got it.
All right. Good morning, everybody, and welcome. Due to COVID-19 and the Governor's Proclamation 20-28, we are meeting today via Zoom only, which we will do until further notice. I don't know if there are many other health policy geeks out there worse than Dave and I, but the public health emergency was just renewed to the end of July. I see Elliot saying yes, she's heard that. So I think while we're making good progress with COVID, we're not out of the woods, and it is germane to why we keep meeting this way. We want to keep people as safe as possible. I kind of say this with a heavy heart. This morning, we are going to be doing introductions, and for the first time in a long time, we will not be calling on Yvette, who has passed on, and Dave is going to be talking about her in just a bit, but I do want to just call out that it's a little bit of a milestone since she served our PEB family for 27 years. Yeah, so board member introductions, and greatest gift we can give to her is she wants us to carry on and do good work. So that's what we're going to do in honor of her. I'm going to do a roll call to identify the board members with us today. Harry Bassi, are you here with us?
Yeah, hi, this is Harry. I am here. Thank you.
Thank you. I see you. A little KU activity there going on.
I thought you might appreciate that from whence you came in Colorado.
There you go. Elliot Weinstein.
Here.
Thank you. Good morning, Elliot. Scott Nicholson, I saw you on.
Good morning.
Hi, Scott. Thanks for joining us. Tom McRobert, are you in presently?
I am.
Thank you. John Comerford.
I don't see John yet, so we'll keep watching for him so we can know when he arrives.
And Leanne Kunze.
Good morning. I'm here. Thank you.
Great. And then also Katie Hatfield from the Attorney General's office. I saw Katie on early. Katie.
Hello, everybody. I'm filling in for Michael Tunick today. So thanks for having me.
Great. Thank you, Katie. And as always, I'm your board chair. I'm Sue Birch. I do have some little Easter bunnies, little great nieces. So if you see a few heads go by, just know for the first time, I've got a few little toddlers toddling around. I'll show them to you if they come by. With board members and presenters attending virtually, it's helpful for the board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are any questions. Board members, we will also watch in case you use Zoom's raise your hand feature to indicate that you have a question. The public, and we'll be watching both electronically and for manual hands, we get it. And if we absolutely don't call on you, you can jump in. The public will have an opportunity to provide general comments at the end of the meeting during the public comment period. So Dave, I'm going to turn it over to you, and you're going to provide us an overview of today's agenda.
Yes. Good morning, Chair Birch and members of the board. We will do a little bit of time traveling and have some minute approvals. And then I have a few follow-up slides that didn't, for topics that were brought up or questions from the last board meeting that didn't fit nicely in any of the presentations later in the day to share. And then I will be, with a heavy heart, sharing some remarks about Yvonne and her service to the state of Washington. After that, we will move into asking the board to take action on 4 resolutions that were presented at last month's board meeting. And then the board will receive a briefing on the rulemaking process. We like to do that just to keep the board aware, even though the agency has the rulemaking authority, we're doing it on behalf of both the agency and the board. And so we like to keep the board apprised of the rulemaking process. Since we last met at the last board meeting, I believe was on the last day of session. So there's just a few last minute things just to wrap up about the most recent legislative process. Then we'll take a break and come back and have part 2 of our discussion on our our dental benefit design journey that could culminate in changes as early as 2024 or 2025. We'll have some specific proposals brought to you for discussion by Ellen. And then we will round out the public portion of the meeting with an update on the PEB modernization project. We last brought a presentation about this at the retreat, and we have some updates on the scope and timeline of that project that we want to share with the board to keep you apprised of our progress on that effort to allow us to leverage technology more than just paper one day. After public comment, we will have our first executive session of this board season to begin to talk about the status of the procurement process, which began in the past month. And with that, Sue, I turn it back to you for minutes.
Sorry about that. Thank you, Dave. And also, Dave, do we have Scott on? I see him in the meeting room.
Scott Palafox or Scott Nicholson?
Scott Palafox.
Yes, Sue, I'm here.
Okay, so Dave, I have one impromptu item to call out. Another person that we need to celebrate today is Scott Palafox. So Scott is probably sitting in for his last PEB board. Scott has been serving the state for 40 years and has been Dave's deputy. Many of you have worked with Scott. And Scott, we are honored that you're joining us probably for your last day, or is tomorrow your last day? Anyways, I just want to note that Scott is here, and Scott, we celebrate you and your years of commitment as well.
So thank you, Sue. I do want to offer some thanks as well in that regards. I first want to acknowledge and extend my condolences to the Tate family as well. There are two things that I will always remember about Yvonne. She didn't have much to say, but when she spoke, everyone listened. And I think the other thing I appreciate about her is that she always expressed her gratitude and appreciation for the staff for all the work they've done behind these board meetings and these presentations. So I do wanted to acknowledge that as well. I wanted to thank the board for the past 8 years of serving this board. And I truly believe it's the work done by this program and the decisions that were made by this board that gave the legislature the confidence for giving us the gift of the SEB program to implement and create. I'd like to thank you, Sue, for bringing in your vast clinical experience to this board. Not only do you bring the tender loving care and compassion of a nurse, and I know that because I'm married to one, but also you bring a deep understanding of the healthcare policy that helps to clarify and provide additional orientation as to what is the driving force behind our initiatives. I'd like to thank Dave, commander of this Starship PEB and SEB program. You have certainly established yourself as a true leader and making your own imprint on the programs, especially following behind Lou McDermott. I want to thank all our partners, AG's office, our external stakeholders, and certainly the public for keeping us on our toes. And with your patience and understanding and your trust in building a good relationship, you have seen the good outcomes and results that come from that. I'd like to thank that admin team that's sitting in that room with Dave, because they are the heart and soul for putting these events together. Thank you for your countless hours of the prep work and for your extended hours burning the midnight oil, especially you, Connie, as you guys all rock. And then lastly, I want to extend appreciation to the Healthcare Authority staff. What can I say? You're absolutely a fantastic group. Without you and all the work that you put forth in getting through these presentations in front of the board, we would not have been as successful as we have been. And I have all the confidence that you will continue that to make things happen in the future. So I wish you all the best of luck. I'll be keeping a watchful eye and ear, and maybe on occasion I might participate in a board meeting providing public comment as well. So thank you all for that.
Scott, we look forward to hearing from you anytime, and you be well, and you just enjoy this next chapter of life. You have so earned it. So, and we'll do a good job making sure your benefits are all like the best. So,
thank you.
All right. Dave's probably cracking the whip on me to get us back on track, but now we're going to move into the approval of the meeting minutes, because I just wanted to make sure Scott had his time. We're going to vote on two sets of minutes. The minutes are behind tab 3. So let's begin with the April 14th, 2021 meeting minutes. Are there comments from the board? I'm not muted, I might know. Okay. So if there are no comments, do I have a motion to approve the minutes as written?
So moved.
Thank you, Scott. And I think the second is from Elliot. All in favor, say aye. Oh, no, maybe not Elliot. Tom seconded.
Yeah. Sue, is it, I'm sorry, is it possible to put it up on the screen? I'm not seeing the visuals for the tabs.
Dave, so it's tab 3. The minutes are behind tab 3.
Right,
And
but
Dave,
usually
we're not seeing anything from the HCA room presentation. I don't know that we post the meeting minutes, but I'm checking with Dave to see if staff can do that.
So I just want to check, are you not seeing a title slide that says Public Employee Benefits Board, April?
Now we are.
It just popped up.
Okay. Yeah, during the minutes, we usually don't flash up the minutes, but I was concerned that you weren't seeing anything. So I'm glad that you're seeing a visual now, but we don't typically put up the minutes as we go. We can think about that in the future. They're not at hand ready to pull up.
Right.
Okay.
I was just seeing the spinning circle, so I was concerned about that.
Thank you, Tom. So again, I refer you to tab 3, and we're looking at those April 14th minutes. And we have a motion and a second. So all in favor, say aye.
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 Great. Are there any? Thank you. Are there any opposed? April 14th, 2021 minutes are approved as written. Okay, let's stay in tab 3 and we'll look for the May 12th meeting minutes. And I'll give you a second to turn to that page. Are there any comments from the board? If not, do I have a motion to approve the minutes as written?
So moved.
Thank you, Elliot. And is there a second?
Second.
Thank you. I think that was Leanne.
Correct.
And all in favor, say aye.
Aye.
Thank you. Are there any opposed? All right. The May 12th, 2021 minutes are approved as written. And now we are going to move into the next agenda item, which is the follow-up from March 10th, 2022 meeting. Dave, you've got some info to share from the follow-up questions at our March meeting, and your meeting materials are behind tab 4.
Right. Good morning, Chair Birch, members of the board again. I believe I have 3 questions that didn't quite fit easily into other presentations to follow up on. First, slide number 2 shows the Medicare subscriber enrollment. I believe, Tom, you asked for this information as we were looking at, I believe it was in the dental plan conversation. There was a question just generally about retiree Medicare enrollment. So we took a snapshot here as of February 28th, and this just shows kind of ranked based just on pure population enrollment. This is subscribers. It's not member lives, so this doesn't include dependents, but it shows kind of overall where the plans are. I believe some of the questions that were kind of percolating were really trying to get a better sense of understanding of how much enrollment was in the United Healthcare plan. So just wanted to provide this snapshot. Again, this is subscriber enrollment, and I'm emphasizing that so much because the next slide, we're going to switch to member enrollment. So subscriber enrollment here. On the next slide, I think this was a question that John Comiford had, and his question was to have a better understanding of what our estimated 5-year outlook estimated enrollment is for the MAPD plans. And so member lives, United Healthcare has told us that based on their experience with someone of our size and introducing a product to this population, that we could anticipate at the 5-year mark being around 10,000 member lives. Remember that we implemented in January of 2021, so we're only about a year and a half into that 5-year piece. And as of March, the beginning of March, a similar time frame to the prior slide, the covered member lives, and that's where we're talking about here, is 10,000 member lives. That includes dependents. Right now, we're at about 4,900 lives. So we're almost at the halfway mark, a year and a half in. And so the enrollment growth that we would project based on the experience that we're seeing so far, we do think that we would achieve that assumed outcome of around 10,000 covered lives by that 5-year mark in 2025. It's possible we could exceed that, but we are on a target that seems like we're validating that is a reasonable estimate of what we think could happen over the next couple of years. Then the next slide, I'm realizing there were 4 questions. The third question that came up was in Jenny Switzer's presentation about the transition to Navitus from MedImpact as the UMP, as part of the UMP Pharmacy Administration benefit. And we had quite a few number of staff and board members who were Googling to try to sort out who owns Rite Aid, where, and when. And so I said, let's pause and come back and we'll describe what the market looks like with Rite Aid. So here's what we can share is that as of January of this year, just a few months ago, remember Rite Aid retail pharmacies are in network for UMP. There was a public announcement that CVS is purchasing Rite Aid, but it's not truly finalized. There's still negotiations that are ongoing, so there's not a lot of information that is shared about that acquisition and or merger status, but CVS there's an announcement that CVS has purchased or is in the process of purchasing Rite Aid. As we get more details, we'll make sure to share with the board what the implications for that are. And this has really led us to discuss with Modus and Navitus how they can be proactive with us when we see these types of bigger market changes to keep HCA aware so that we can keep the board aware of them. So this was a good exercise from the last board meeting to reinvigorate kind of some of those processes so that we have a more proactive conversation about these market movements that happen. So the answer to the question is Rite Aid is going to be owned by CVS. No more Googling needed at the moment. So we'll keep you apprised as we learn more about that transition and if and what it means for UMP. And then the last piece that I have a follow-up, it wasn't really a question, but during public comment, we had a member from Eastern Washington University who raised questions about the health savings account administration, that's health equity. As a reminder, HCA doesn't have a direct contract for health savings account administration services. Health equity is a subcontractor of all of the medical plans. So both Kaiser regions as well as regions for the Uniform Medical Plan. So we don't have a direct contractual relationship with health equity, but health equity is the subcontractor of all of the medical plans. And what we do know and is that at the end of last year and the beginning of this year, health equity had a very significant staff shortage, that they were been in a hiring blitz and reinvigorating of their staff and training. And so many of their measures had longer response times. And so, for example, the specific question or point that was being made, one of them being made during public comment last meeting was about the gentleman wanting to transfer his funds out of health equity and into another account because the member owns the funds that are within that health savings account. And we learned from health equity that during this short staffing period that process was taking 4 to 6 weeks. And it turned out that this gentleman's transfer occurred in that 5 to 6 week range. So he did ultimately get the funds transferred to the custodial administrator that he wanted. And so that part has worked out, but we learned more of the why that was happening. The other piece that was raised was about investment fees. And so I wanted to share a little bit about what the investment fees are within those subcontract relationships. There is a monthly 0.03% fee that caps at $10, but there are investment options that avoid any fees. And so depending on exactly how participatory the member wants to be with the investment aspect of the account, and a member isn't required to invest in the account either. They do have to affirmatively opt into an investment. And when they invest, they have options that include not having fees. So that's what the current investment structure is. We did reach out to the member from Eastern Washington and shared this information. And like I said, the money from his HSA account were So we are, I will say we are actually going to bring a presentation to the board next month that we are working on a procurement for the next contract for our tax advantaged account administration. We think of that, and today we have an administrator for our FSA and DCAP, which are both very similar types of tax preferred accounts. We are looking in that procurement about also having the same vendor directly do HSA administration on behalf, so that we have that relationship closer to the healthcare authority, so that we can monitor it more closely and have our own direct accountability with the services that are being provided to members. So as we hopefully bring that into the fold within contracts directly here at HCA, we'll be able to do some more monitoring and have more robust discussions about some of the performance expectations and performance guarantees and investment strategy options. So that's kind of a preview of coming attractions, but it's something that many vendors who do FSA and DCAP also provide HSA services, and it just seems like it's a good idea for us as an agency to consider including that directly as a vendor partner here at HCA. So those are the follow-ups I have. I want to see if there's any questions about any of these follow-up topics before I move on.
Dave, I'm not
All right.
seeing anybody's signal. Do you want to take us into our next agenda item? We want to do a special tribute for Yvonne.
Yes. Just two other quick things. When you see board staff members' backgrounds today, I just want to highlight that we're seeing Whatcom County. And then I didn't get to say my 3 cents about Mr. Palafox. I just want to thank him publicly as well. The past couple of years, as we were doubling the program and bringing things up, I definitely needed a confidant, and Mr. Palafox was part of that. I've done several public tributes already. I don't know that there's much more I can say, but I just wanted to also publicly thank him. He has his last day tomorrow, so his retirement clock is at 14 hours and 36 minutes, to be precise. So looking forward to hearing from him in the public. But now I'm going to move us into another celebration of sorts, because Yvonne's family is having a celebration of life services to honor Yvonne's impact. And I want to take a moment to talk about her impact here at HCA and the state of Washington and residents of the state of Washington and the PEB program. I thought quite a bit about how to talk about Yvonne's impact. I'm not sure how many people saw her obituary in the Seattle Times this Sunday, but I think there's just a little bit of her journey that led to Washington State that's really important to understand her background. And so, you know, she was a military child and bounced around different parts of this country as well as Europe. And then that led her ultimately to her undergraduate studies at Kent State University, where she was president of the residence halls and present during the 1970 Kent State shootings. So talk about a perspective that she has on the world, and that being part of that moment in history that so many of us, or hopefully all of us, are aware of the impact, and thinking about how that shaped her as a leader, being in a residence hall leadership role at Kent State at the time. It's just kind of, it's an interesting part to her journey in life and just the perspective she brought to the board and to the world. She ultimately went to law school in Colorado, and that led her to working at a former iteration of the Office of Civil Rights in DC for a federal agency. And then she transferred over to Seattle, and then she planted roots here more permanently in the Northwest in the 1980s. She then transferred into human resources roles at various organizations here in the Northwest. First with Group Health Cooperative, and after talking with her daughter, I start to hear about some of the commitments that she had to equity and diversity and inclusion from the very beginning. She helped found one of the original LGBT groups at Group Health for employee support. And her daughter fondly talked with me about remembering marching with Group Health in Seattle Pride parades in the late 80s, early 90s. Certainly in our history standpoint, not something that was controversial, particularly at that point in our nation's history. She then became the director of human resources at the Port of Seattle, and that's where she entered her PEB work. She was appointed by Governor Locke in 1998, right after she became director at Port of Seattle, and she's been on the board ever since. And while she was at the board, she then transferred to becoming the HR director for the city of Bellevue, where she retired in 2014, but she continued service here at the board. So that's kind of some of the experiences that led her to us. And when we go back, so Governor Locke appointed her, Governor Gregoire reappointed her for her entire administration, and Governor Inslee continued supporting Yvonne on the board by appointing her up through a recent appointment this last fall. So we have, 24 years of service on the PEB board. I went back to there is footage of the 1998 meetings, and Yvonne's first meeting was in May of 1998, so almost exactly 24 years ago. And it's kind of funny when you start to think about, nothing new ever happens or no new ideas. That one of the topics in May of 1998 was the new long-term care benefit being offered under the PEB program. And so that long-term care program ultimately sunsetted in 2014 under PEB, and obviously we all know where the long-term care debate is in our state these days. But her first board meeting involved a discussion about long-term care. And that same board season, when as we get to the end of the board season, there was a discussion on whether Viagra should be approved as coverage within the Uniform Medical Plan. And Yvonne immediately brought up gender equity and how she had concerns about approving Viagra when there was not gender equivalent contraceptive coverage to her satisfaction for women, and that she had a hard time supporting Viagra if there wasn't contraceptives yet. And so that just speaks to the very beginning of her push for diversity, equity, and healthcare. And so I just wanted to share that brief story about her first season on the board. But I think it's also important to look at, what changed over time in her 24 years of service. So just a little bit of tour on some of the topics. One of the next big ones that I think is just speaks to the testament and power of a board like this was in 2000, when the board took a very courageous step to approve benefits for same-sex partners in a domestic partner registry that was run by the Healthcare Authority. This was just 2 years after the legislature overrid the Defense of Marriage Act that was signed into law, prohibiting same-sex marriage in the state. And the minutes and record of that meeting show that it was quite the trial and tribulation for board members. There was heavy lobbying on both sides on that issue, and the board took the step of approving same-sex and recognizing those partners and creating that access to benefits. And again, so it's just a testament to the things that this board can do and the power it can have on individuals' lives, and something that I know after talking with Yvonne Sauter that she was very proud to be a part of that now less than controversial decision, but certainly a controversial decision in the year 2000. The entire concept of the retiree deferral rule, being able to maintain eligibility while having access to other types of benefits, that didn't exist when Yvonne started on the board. And so the entire modern iteration of being able, for a retiree, being able to have some choice and access to come in and out of PEB within certain parameters, that was part of Yvonne's tenure as she watched the board. We talk about 2-year averaging in higher education for part-time workers. That was a concept that didn't exist when Yvonne started on the board and came into fruition in the mid-2000s. Then the creation of the consumer-directed health plan and that tax-advantaged account that allows people to be more participatory in their healthcare benefits and have investment strategies for the future. Another change that Yvonne saw. In the last couple of years, there was transgender benefit, access to transgender benefit coverage. And again, those board meetings, there was intense lobbying about that and some scrutiny for the decision that the board made to advance coverage for transgender benefits. And then I like to think of some of the most recent pieces during my tenure as director. I know that Yvonne would always laugh when I say, well, we're going to work on the life insurance benefit, which hasn't been worked on since 1993 or 1970. She was like, that's longer than my tenure. And I know she was very happy to be able to support advancements both on the life insurance benefit and the long-term disability opt-out change last year. so those are just a few of the changes. And you think about on a federal level, when Yvonne started on the board, Medicare prescription Part D didn't exist. The ACA didn't exist. All of these massive changes while she was on the board, and that had ripple effects and decisions that the agency brought questions and policy positions for her and all of you. It's just the tenor of the work. When I think about Yvonne's tenure, I really think about I think Scott said it well. She was very deliberate in the words that she chose. She was never jaded. She was always proactive, calm, measured, and that was a real stabilizing force. I hope for new board members, she probably was someone that new board members look to for her tenure, and she saw many board members come and go over 24 years. So I hope that you as board members experience some of what I experienced whenever I became the director and looked to board members to understand their perspective. She had such a valuable perspective. And I think importantly about last January when we had the equity panel discussion, and we were about to close out the panel and move on to the next topic, and Yvonne slowly raised her virtual hand, and she said something that I still think about to this day when we have equity conversations, and that's she gave birth in a DC hospital and everyone in the room looked like her. When she came to the Pacific Northwest, she never expected everyone in the room, if she went and had another baby, to look just like her. And what she really wants, though, and what she needed is some providers who are culturally competent to understand what she needed based on her experience and her race and ethnicity. And that really struck a chord with me because as an openly gay man, I think about that with my own providers. I don't need to have an LGBT provider. I need somebody who's going to ask the right questions and also not ask the questions that shouldn't be asked in 2022. And so I just think about that profound voice. And when she said it, it immediately resonated with me. And I hope that it resonated with others because that's the kind of power that her viewpoint brought to our discussion. So I couldn't go this meeting without saying a few things. I did reach out to some of the past directors of the program that she was a board member under. And when she first joined the board, Mary Ann Lindeblad was the then PEB director, our recently retired Medicaid director, and she did send me a message to read. And it was over 20 years ago. When I first met Yvonne was always a voice of reason on the board. She truly cared about individuals served by the PEB program and worked to find ways to improve benefits. She used her background to help find common ground and balance on how best to serve PEB members while being cognizant of her important role in ensuring costs were balanced against benefits. During difficult benefit design discussions, Yvonne put members first in her advice and direction and helped guide and support staff in resolving the areas of disagreement. She will be missed. So that's from her first director, my comments from her last director. I do know that at least Lou has joined briefly, and Lou wanted to say a few comments. So Lou.
Thank you. Two things. One, Scott, I just wanted to wish you the best in your retirement, bud. Scott and I have worked together for over 25 years. He knows how I feel about him. If it wasn't that he put in 40 years, I would be begging him to stay. But I suppose after someone puts in 40 years, there's really not much you can say when they want to go spend more time with their grandkids. So, Mr. Palafox, I wish you 100% the best.
Thank you, Lou.
As far as Yvonne goes, I just wanted to say the relationship between the director of PEB and the board is extremely special. And I know sometimes it might feel like we're just kind of going through the process and getting to the next board meeting and trying to get through the season. And we've got certain things we're trying to advance and we're dealing with certain circumstances that happen outside of our control. But as an agency, it is very difficult to manage a board and to make sure that the will of the board is implemented. And because you're all different, the board members are all different, and Yvonne was no different than any of you. She was her own person. She spoke infrequently, but powerfully. And during my time, I would always make sure that when I spoke with Yvonne, that I knew what her thoughts were about various subjects, because what I didn't want to have happen is I'm going off in one direction that I think is the right answer, that the agency thinks is the right answer. And then something happens during the board meeting. And if Yvonne disagreed with it strongly and took us by surprise, her voice carried a lot of weight. And that could cause a lot of issues on our end. You know, it's a delicate balance between the board, the agency, the governor's office, and the legislature, trying to maintain that balance and to get things done. It's difficult. So I always really appreciated her presence, the power in her voice, her calmness, and yet don't let that fool you, her calmness, because she was a force. And if she felt strongly about something, she was going to make sure it was well known. So I just wanted to come today and just thank her for the time that she spent with us. I'm sorry she's gone, but she contributed greatly, obviously, to this program and to her fellow Washingtonians. And so it was just an honor to work with her. So I'm sad to see her go. I honestly thought I was going to retire before she ever left the board. So I'm going to her service, and I would like to be able to speak at her service as well and say a few words about her. So you all have a good day. Thank you. And Dave, I appreciate everything you and your staff do. You take care.
Thanks, Lou. So really, I too just have a special place for Yvonne. I think it says it all when I was talking with her daughter. She said, you know, she just didn't want to tell you guys kind of what was really going on because she didn't want to leave this work and the team. And I think it really says just so much about her and her public service and her commitment towards equity and health, and just so engaged and always available, and just really poured her heart and soul into the work we all do together. So I really think we have to stand on her shoulders, you know, the shoulders of giants, and continue her work. I think it's the best tribute we can do. And we're so fortunate to carry on. We will be looking for new board member nominations, and a commitment to her push for greater DEI. I think it's really important that we try to continue to balance out our board composition in her honor. So Dave, I think she would right now be saying, come on, you guys, get on to work, enough. But what two superstars that we've all crossed paths with, both Yvonne Tate and Scott Palafax. And honestly, we celebrate both of you guys, and we'll carry on. That's what we can do. I saw a hand up. I think, did I see a hand up? Was it Tom, or maybe that was an old hand up?
Sue, I don't know how my hand got up because I did not touch that screen, but it was up, yes.
No worries, no worries. Dave, I think it's time that we move on to our next agenda item. And what I'd like us to do, now that we've just, do you all feel like we need a moment of silence, or just time to collect your thoughts? Are we okay to move on? It's a little hard to tell. I see some heads shaking and thumbs. Do you want to stand up just for a minute, or? I'm not seeing any heads shaking. So we're going to move on. We're going to carry on in their honor. The next agenda item is the policy and rules development. Stella Nye is with us. She is our policy and rules coordinator, and also Emily Duchesne, who is our regulatory analyst for policy, rules, and compliance section of the PEBB division. They're back with the 4 resolutions that were introduced in March and scheduled for board action today. After their presentation on a resolution, I'm going to read the resolution, and then I'll ask for the motion to adopt and a second. I'll invite public comment on the resolution. I'll ask for discussion from the board until we are ready for a vote. But first, let's hear from Stella and Emily. And again, their materials are behind tab 5. And thank you, both of you, for being here.
Thank you. Good morning, Chair Birch, members of the board. For the record, my name is Stella, Policy and Rules Coordinator for the PEBB division. Today, Emily Duchesne and I have 4 policy resolutions for the board to take action. Next slide, please. This slide and the next two slides are included in the presentation, so you will have them available as you consider the policies we will discuss. Slide 5, please. Here are the 4 resolutions for action today. I will go over the first 2 resolutions, and Emily will go over the last 2 resolutions. The first resolutions would address allowing more retirees the option of enrolling into Medicare Advantage with prescription drug plan by addressing the gap months. The second resolution would address deferring PEB retiree insurance coverage when the subscriber becomes eligible for the employer contribution. Next slide, please. The third resolution would address employees returning to work from active duty, and the final resolution would address dual enrollment situation. Next slide, please. We have some follow-up on board members' questions from the March 10th board meeting. One question was why Uniform Medical Plan Classic is the default plan, and Dave provided several reasons. One, UMP was the basis when beginning to develop the benefit design for the UHC plans, so it should be an easy transition from one plan to the other. 2, UMP is the plan with the most enrollment, so for many, the transition will be easier. 3, UMP is available to all of our retirees, not limited to a regional service area. And I would like to add an additional reason because the board adopted PEB 2020-05 back in 2020 by enrolling non-Medicare enrollees to the UMP Classic plan when a subscriber elects to enroll in an MAPD plan. By using UMP Classic as the plan during the months prior to the MAPD coverage begins, would maintain consistency when addressing past board policy. And you can find a copy of the resolution PEB 2020-05 in the appendix for your reference. And next slide, please. There was another question from the board about why the federal government does not allow Medicare enrollees enroll or disenroll at any time, and why are they being restricted to the special election periods. The following response on the slide was extracted from a response by the Centers for Medicare and Medicaid Services when implementing Medicare Modernization Act of 2003 during public period comment in 2005. Congress intended Medicare enrollees to make plan changes during the annual election period when implementing Medicare Modernization Act of 2003. Permitting beneficiaries to discontinue Part D coverage at any time during the year without a corresponding election period to enroll in such coverage could result in a gap in coverage and a Medicare Part D late enrollment penalty. Many of the special enrollment periods we have today were established when Congress implemented the Balanced Budget Act of 1997. They set specific parameters in which elections can be made, change. CMS has historically included in the regulations those SEPs that have been specifically named in the statute and established special enrollment periods for exceptional circumstances in their operational guidance. For employer-sponsored Medicare Advantage plans, our annual OE, open enrollment, and our special open enrollments are considered as special election periods as allowed by employer-sponsored group health plans.
Real quick, Stella, I just want to acknowledge that you did a lot of work to identify this, and many times when you go down the rabbit hole of why does the federal government do anything, there's very little to nothing, and this time it is very clear from some of the documentation from the congressional record as well as CMS regulations that it was very purposeful, which doesn't necessarily get to the why as well, but it does a little bit, but it definitely was not a misinterpretation. It is quite clear from the pieces that Stella record, that it was very purposeful that it's supposed to be prospective. So just to avoid that gap situation, it was very purposeful. So I just want to thank Stella, because going down that rabbit hole often produces nothing. And then to actually find a specific answer in less than a month with federal documentation that goes back 30 years, I just appreciate your work.
You're welcome. If there's no questions, then we will move on to the next slide. We revised the proposed resolution 2022-03 to reflect the non-Medicare dependents will also be enrolled in the UMP Classic during the gap months prior to when the MAPD coverage begins. The original proposed resolutions and examples are placed in the appendix for your reference. Are there any questions before the board takes an action?
I'm not seeing any hands. Dave, Connie, you tracking any on screen?
Not seeing any at this point, Sue, so I think you can go on to.
Okay. So this is going to be our first vote. The resolution PEB 2022-03, the Medicare Advantage Prescription Drug Plan enrollment during gap months. Resolved that if a subscriber elects to enroll in a Medicare Advantage prescription drug, otherwise known as a MAPD plan, and the required forms are received by the PEB program after the date the PEB retiree insurance coverage is to begin, the subscriber and their enrolled dependents will be enrolled in Uniform Medical Plan Classic during the gap month prior to when the MAPD coverage begins. Is there a motion to adopt?
So moved.
Thank you. And is there a second?
Second.
Great. Any comment?
Leanne with Tom.
Thank you. I was having a hard time. Thanks, Dave. Are there any comments from the audience? And staff, if you'll help us monitor if anybody's trying to weigh in here.
Not seeing anything, so.
Okay. Are there any comments from the board? If not, this will be a roll call vote. I'll begin with Harry Bossi.
I vote yes.
Thank you. Elliot Weinstein.
Yes.
Scott Nicholson.
Yes.
Tom McRobert.
Yes.
Leanne.
Yes.
Great. And this is Sue Birch. I vote yes as well. So resolution PEB 20-2203 passes. Stella, why don't you please continue to go on and present the information about our next resolution.
Thank you, Sue Birch. Next slide, please. We received one stakeholder feedback on resolution PEB 2022-04, and questions on other topics not related to the resolutions were also addressed. The feedback related to this resolution was regarding faculty who return to teach post-retirement and do not want to disenroll from their retiree medical to enroll in coverage for 3 months and then have to re-enroll in retiree medical. Federal Medicare secondary payer rules require employers to offer employees over the age of 65 the same benefits under the plan and the same conditions as any other employee under age 65. Federal law prohibits an employer from offering any financial or other incentive for an employee entitled to benefits not to enroll under a large group health plan, which will be primary payer of claims to Medicare. For the PEB program, there is a Medicare retiree premium subsidy provided to subscribers and spouses enrolled in PEB retiree insurance coverage. Employers also may not contribute to Medicare supplemental plan for those who have and whose spouse has current employment status. The proposed PEB board policy proposal, PEB 2022-03 for automatically deferring PEB retiree insurance coverage is being recommended, so all employees will be treated the same and in line with the Medicare rule. Are there any questions before the board takes an action?
I am not seeing any hands. So we're going to go ahead and take a vote on Resolution PEB 2022-0404. This is deferring the PEB retiree insurance coverage when the subscriber becomes eligible for the employee contribution. Resolved that PEB retiree insurance coverage will be automatically deferred when the subscriber becomes eligible for the employer contribution towards PEB benefits. The subscriber will be exempt from the deferral form requirement. Is there a motion to adopt?
So moved.
Thank you, Leanne. Is there a second?
Second.
Thank you, Tom. Are there any comments from the audience?
Not seeing anything, Sue.
Okay, I'm not either. Are there any comments from board members? If not, we're going to go through a roll call vote again. Harry?
Vote yes.
Elliot?
Yes.
Scott?
Yes.
Tom?
Yes.
Leanne?
Yes.
And this is Sue, and I vote yes as well. So Resolution PEB 2022-04 passes. Now we're going to move to Emily, who's going to present the information about our next resolution. Thank you, Stella.
Thank you, Chair Birch.
Thank you, Chair Birch. Good morning to you. Good morning to members of the board. My name is Emily Duchesne, and I am the regulatory analyst for the Policy, Rules, and Compliance section. As stated before by Stella, I have two resolutions for the board to vote on today, and this slide is included in the presentation, so you will have it available to you as you consider the USERRA policy. Next slide, please. Resolution PEB 2022-01 has been revised since the March 10th meeting. We'd explained at the time we introduced it that we determined the correct language needed to be employer-paid PEB benefits and not health plan coverage. So we made the change accordingly, as you see here. Next slide, please. And we did receive one technical question from a stakeholder on use of the words health plan coverage. And our response to them was that we just explained that the final proposed language would be revised to say employer-paid PEB benefits. So are there any final questions on this resolution or before you consider taking action?
Emily?
Go ahead.
Emily, I'm not seeing any. So
Okay, good.
I'm going to go forward with the vote. This is, again, Resolution PEB 2022-01, the employees returning to work from active duty. And we resolved that when an employee who is called to active duty in the uniformed services under USERA loses eligibility for the employer contribution towards PEB benefits, they regain eligibility for the employer contribution toward PEB benefits the day they return from active duty. Employer-paid PEB benefits will begin the first day of the month in which they return from active duty. Is there a motion to adopt?
So moved.
Thank you, Elliot. And is there a second?
Second.
Leanne, thank you. Are there any comments from the audience?
I'm going to count myself as the audience for a moment, Sue. We've just realized on the visual you're seeing right now and in the book, this should be Resolution 2022-01, not 2021-01.
Oh, gosh.
You are saying it correctly. We will reflect the record. We'll update that in the record, but I just want it noted in the minutes that it really is 2022-01.
Oh, my goodness. Thank you, Dave.
And Dave, I read it correctly, 2022. I noticed that too. I apologize for not calling that out. So this is PEB 2022-01, but what you are seeing on slide 14 is the correct verbiage except for the year date. All right. So I believe we had a motion, we had a second, no comments from the audience except Dave's clarification. Are there any other comments from the audience? Are there any comments from the board? All right, roll call vote again. You guys know the drill. Harry?
Oh, yes.
Thank you. Elliot?
Yes.
Scott?
Yes.
Tom?
Yes.
Leanne?
Yes.
And I'm Sue, and I vote yes as well. Resolution PEB 2022-01 passes. All right, Emily, please present information about the last resolution that we're considering today.
Thank you very much, Chair Birch. And I will say my apologies for and I did peek ahead at the next resolution. It also says 2021. So the record will reflect that it's 2022. And again, apologies for that. Okay, so let me just say about this slide and the next slide, we've included these in the presentation, so you will have them available as you consider the dual enrollment policy. Thank you so much. And we did not receive any questions on this. And again, it should say PEB 2022. Are there any final questions on this resolution before you consider taking action?
All right, we are going to take vote on resolution PEB 2022-02, employees may waive enrollment in dental. And resolved that an employee who is eligible for the employer contribution towards PEB benefits and who waives enrollment in a PEB medical plan when they are enrolled in TRICARE, Medicare, or other employer-based group medical and are not enrolled in SEB medical may waive their PEB dental only if they are enrolled in both a SEB dental plan and a SEB vision plan as a SEB eligible dependent. Is there a motion to adopt?
So move.
Thank you, Tom. Is there a second?
Second.
Thank you, Scott, or Harry, or both. And we're going to roll call vote this. Oh, I'm sorry. Any comments from the audience? Dave, I'm not seeing any activity. Board members, any comment from you? All right, we're going to move into the roll call vote. Harry?
I vote yes.
Thank you. Elliot?
Yes.
Scott?
Yes.
Tom?
Yes.
Leanne?
Yes.
And this is Sue. I vote yes as well. Resolution PEB 2022-02 passes. Emily, why don't you go ahead and finish up your presentation?
Thank you very much, Chair Birch. Next slide, please. Okay, so just to wrap this up, the next steps are we will issue guidance to the employing agencies on these resolutions, and then we will incorporate the resolutions into the PEB program rules. Next slide. Are there any questions? All right, well, thank you very much, Chair Birch, to you and to the members of the board, and I hope you have a great rest of your day.
Thank you, Emily. All right. Next on deck in our agenda is the 2022 legislative session wrap-up. Cade Walker is our executive special assistant. He's going to provide a.
I think there should be a presentation from Stella again at the. Oh, it's at the bottom of page 7 of your annotated.
Oh, I'm sorry. Okay, sorry, Cade. I jumped ahead. See, it's not just Emily goofing things up. I apologize. Thank you, Dave. Agenda item 2022 annual rulemaking. Stella, back to you for sharing the timeline and the focus of HCA's annual rulemaking. And her materials are behind tab 6.
Thank you, Chair Birch. Good morning, Chair Birch, members of the board. For the record, again, my name is Stella, Policy and Rules Coordinator for the PEB Division. I'm going to go over high-level information on this year's rulemaking and highlight the most significant changes and rulemaking actions we are considering making. No action is needed from the board for this briefing. Next slide, please. Here's the rulemaking timeline. In May, we will file CR 102, which is the proposed rulemaking on our proposed amendments and new rules with the Code Revisor's Office. In June, we will conduct a public hearing on our proposed amendments and new rules. After the public hearing, we will file CR 103, which is the rulemaking order, and adopted rules will be effective 1/1/2023 to align with the new plan year. Next slide, please. The focus of this year's rulemaking is divided into 3 different areas. We're adding clarity to rules to better administer and manage PEB benefits as identified by staff and stakeholders. We are making changes to implement state legislation and to comply with federal requirements. We will implement 4 PEB board policy resolutions that just passed by the board earlier at this meeting. Next slide, please. Under administration and benefits management, we are making global changes to include the addition of limited purpose flexible spending arrangement. We are including information on the methods to use when a subscriber wishes to cancel supplemental dependent life insurance and accidental death and dismemberment insurance coverage. Next slide, please. Post the implementation of changes to the long-term disability insurance benefits, we noticed they should have been added to the rule, and we're adding it this year, that an employee who is on a leave of absence and maintains eligibility for the employer contribution will have their premiums waived for the employee paid long-term disability insurance for the first 90 days. And we are amending PEB program appeal rules related to the brief adjudicative proceedings and formal administrative hearings. The amendments include to clarify that both the appellant and the HCA may request review of an initial order. We're adding new sections related to the petitions for the judicial review within the current process. And we are creating a new section on how to request a review of the initial order issued by the Office of Administrative Hearings. Next slide, please. Under regulatory alignment, we made a few changes to align with federal regulations, and this includes clarifying employees cannot enroll in a medical flexible spending arrangement and a limited purpose flexible spending arrangement in the same plan year. We're clarifying the special open enrollment applies when an employee's dependent has a change in their own employment status that affects the dependent's eligibility or another dependent's eligibility, such as a dependent child, for the employer contribution toward the dependent's employer-based group health plan. An example would be Emily and Aaron have a son named Bobby. Both Aaron and Bobby are enrolled in Emily's PEB insurance coverage as dependents. Aaron goes to work for Boeing and he becomes eligible for the Boeing employer group plan, and he wants to enroll Bobby to his coverage. Our current special open enrollment rule doesn't allow the child to be disenrolled, and we're clarifying in rule to allow both the child and the spouse to be disenrolled so that they can both be enrolled in the Boeing plan. And I'm seeing a hand.
Yeah, Elliot. Elliot,
Yes.
you ask your question.
Stella, you totally anticipated my question. I'm going to recommend both in the rule when it's published, and I would have loved it in the materials if you'd had the excellent example that you just gave me. Because if I don't understand this, I think sometimes a rule having an example, I used to write rules for the Department of Retirement Systems. It helps to have an example. And as I said, that example answers all the questions. So it will help employees and the what do you call it? You know, the human resources departments to understand what's going on. So I urge you to include that example when you publish the rule.
Thank you for that, Elliot. Stella, go ahead.
Yeah, thank you for the suggestion. We will include that in our communication materials. Thank you. Are there any other questions?
Stella, I'm not seeing any.
Okay.
Thank
Thank
you
you very
for-
much.
Thank you, Stella. All right, now we're going to move on to the 2022 legislative session wrap up. This is our next agenda item, and Cade Walker, who is our executive special assistant, is going to provide a final wrap up of this year's legislative session. Cade, there you are.
Thank you, Chair Birch, members of the committee. I'm here to provide the last of the season's legislative updates. We wrapped up the legislative session last month. It seems like it was a lot longer ago, but we're happy to be out of session. And for the most part, I'd say we made it through unscathed and no worse for wear. A good grind of a session, but I think we made it through, and our analysts did a great job. So again, I always want to make sure I give a lot of appreciation to our analysts who spend a lot of time hopping up as soon as they're called up to do an analysis for a piece of legislation that just dropped. They drop everything that they're doing, get those analyses done, and our team did a great job this year. So much appreciation to all those analysts listening, and we'll be doing it again next year.
And Kate, I did not call out that your materials are behind tab 7. So board members, you have these. I'm sorry, back to you, Kate.
Oh, thank you, Chair. I don't know if I saw a hand up for a moment, but I will, I'll assume that if there's another question, I'll see it come back up.
It was applause about your staff and handling a volume of work.
Yeah, thank you to them. Yeah, thank you. Next slide, please. We'll get into this and some of our numbers real quickly. We did have just under 170 bill analyses that were done. These are the analyses that are done on any piece of legislation that is dropped throughout the session. We also had 70 fiscal notes. It was a new high watermark for us. And I only mention that because fiscal notes are a pretty significant effort. Normally, the bill analysis process allows for 3 days for our analysts to have their analysis done, to read the legislation, think hard about it, apply different lenses to it, write down their analysis, get the analysis approved by multiple people. But when there's a fiscal note, that whole process is truncated into 1 day. They are a significant amount of work. It is something that we're very conscientious about, making sure that the fiscal impacts of any legislation that's being proposed is thoroughly vetted and put forward so that there's no surprise, as minimal surprises on the financial side of things for new legislation. So again, kudos to our staff for all this work. Next slide, please. Here's our funnel of the progression of how a bill becomes law. These are just on the high priority bills that the ERB division is responsible for the analysis on the agency side. We had 7 bills this year that made it all the way through the legislative process and have since been signed by the governor. And I'll be going through some of those bills next. So next slide, please. I think some of these I've talked about and mentioned several of the meetings prior, but we'll still go through them. If there's any questions about more details about any of the pieces of legislation, feel free to stop me. I'd be happy to provide additional information that I have, or go find more additional information if I don't have it off the top of my head. So starting out with House Bill 1052, this was legislation that was from last session that was carried forward by rule to this session. It passed without a single no vote, and this is pertaining to ultimately what we would refer to it as the performance guarantees in our contracting with our carriers, permitting that practice that we have been doing, as well as the industry at whole, of allowing large group employers to utilize performance guarantees in their contracts. This is aligning our insurance code and was passed and signed by the governor. Excuse me. House Bill 1688. This is further expanding on the protections regarding what are referred to as balance billing or surprise billing, further extending the scope of services that are precluded from balance billing being applied to, extending services to things like rehabilitation services after an emergency room visit, so that the members aren't, anyone who's covered by insurance aren't receiving bills for providers that are out of network when they had no ability to control the services being provided by an in-network provider. A really great consumer protection bill that was furthered this year, and also in alignment with a lot of the federal protections that have just come into operationalization this year from the federal side. House Bill 1689. This is removing some barriers for biomarker testing, removing some of the prior authorization barriers for individuals who have certain types of cancer. 5532, the Prescription Drug Affordability Board. This establishes the Prescription Drug Affordability Board that will be housed within the Healthcare Authority, has parameters about which of the type of medications can be reviewed by the board, and then the board would then make recommendations about pricing moving forward, subject to legislative session timing. Next slide, please. 5546. Legislation, this is expanding on legislation that had been passed a couple of years ago that capped the price of a 30-day supply of insulin at $100. This 5546 legislation for the 2023 plan year caps the price of a 30-day supply of insulin at $35 for the 2023 plan year. I think there's an expectation that the insulin work group that we'll speak about just briefly in a moment will continue to provide information that will then be used for future legislation at working to control the costs of insulin and other diabetic medication. Senate Bill 5610, prescription drug cost sharing. This is legislation that is helping to reduce the out-of-pocket costs for members when there is a third-party payer, either a manufacturer coupon or something else that can be applied to the price of the prescription drug for a member, that cost is applied to the cost-sharing portion for that member, whether it's for their prescription cost sharing or their overall cost-sharing obligations. And then last on our high priority bill is 5702, providing that requiring coverage for human donor breast milk for newborns, making sure that is a service that can be covered under insurances, as it's a vital source of nutrients for children, and just appreciating the importance of that now having it be a requirement for insurance coverages there. Next slide, please. Some other pieces of legislation that we wanted to bring to your attention that did pass this last session. House Bill 1329 regarding open public meetings. Largely what this is doing is codifying some of the emergency provisions that had been put in place when the pandemic started regarding open public meetings. It does things like states that when we've returned to in-person meetings, that there is an electronic option that is available for requiring that we conduct ourselves in hybrid meetings, which I don't think will be too much of an issue for these boards, the PEB and SEB boards, or any of the other boards that the Healthcare Authority works with. I think we've integrated the technology front pretty successfully. So it's just further codifying that for open public meetings moving forward. 1651, postpartum contraceptive, ensuring that there is coverage provided for contraceptives closer to postpartum time for recently pregnant women. 1675, this is pertaining to removing some of the administrative barriers for manufacturers of certain devices that are used for dialysis, not having them subject to certain restrictions that otherwise would limit their ability to provide those devices to individuals. 1728, this is what I had mentioned prior. The insulin work group has been reauthorized and granted additional funding and other areas that they are being instructed to look into and provide reports back out to the legislature. 1761, allowing for emergency department nurses to provide opioid reversal medication prescriptions to individuals who present to the emergency room for an opioid overdose. This is further making sure that we can get naloxone and other life-saving medications out there as we continue to combat the opioid epidemic. 1851, abortion care expands the authorization of providers that are authorized to provide abortion services, and further ensuring that there are protections for women to be able to seek critical healthcare services as it pertains to abortion and other reproductive services. 1881, birth doulas, requiring the Department of Health to create a license or certification program to license birth doulas, so that birth doulas can then be covered under insurance plans. Currently, because there's no licensure or certification program for them, I don't think there's a licensure program for them, that they're not able to be covered as a sole provider. Oftentimes, birth doulas are maybe part of a bundled care, but now having the Department of Health create a licensure program for them will mean that doulas can be reimbursed in their own right from insurance plans, which I think is a really great step forward. Next slide, please.
Hey, before we move on, Sue, I think you have a question or comment?
Oh, yes.
Yeah, Kate, sorry. I just want to point out to the board that everything on slide 6, these are all significant equity issues. So for the folks that work for the folks that we cover that have kind of unique needs and or might be on less livable wage incomes, these sorts of advances really help create a lot of continuity and are all efforts to really start moving into greater diversity, equity, inclusion, and health equity space. So just wanted to point that out to the full board.
Thank you, Chair Birch. I think that's a great point. Sorry, Dave, was there something from you, Dave?
I have a different comment. So if you have something to keep going on equity.
Yeah, I really appreciate that comment, Chair Birch. And I also wanted to share that this year, a little bit different than what we had done in prior years, or just an expansion on the way we do our analysis this year, is that we did have an emphasis put on making sure that as we reviewed legislation, that not only were we looking at it through a diversity, equity, inclusion lens, but we were also really making conscientious efforts to view things from a health equity standpoint and have that be included in part of our analysis. The ERB division was part of a pilot program within the HCA to have our analysts be trained, provided with additional material to help build a lens that they could be viewing the legislation with a focus on health equity. And I think it was rather successful being able to not only have our analysts see things, be able to view the legislation through that standpoint of how is this improving health equity, but then also to be able to write that down, share that broadly across the agency, and then provide that feedback to the legislature to let them know that that is a priority that we are also seeing, and that that's how we're viewing the legislation, is not only through the fiscal lens, not only through the administrative lens, but also through that lens of what is going to be helping to improve health equity for our state. So Dave?
Thanks, Kate. I do want to comment just a little bit about the Open Public Meetings Act, House Bill 1329, and this board, just a little bit more. I just want to reassure the board and public and clarify that while the state public health emergency is in effect, we'll continue to host board meetings for the PEB and SEP board exactly how we've been hosting them for the last 2 years, as we're having it right today. Once the state public health emergency is lifted, then we will be, at that point, we will move to a hybrid meeting where we have a physical space here at the healthcare authority like we did pre-pandemic, but we will continue to provide access to the meetings in the same manner that we provide today. For those of you who have been longstanding participants in PEB, you'll remember that pre-pandemic we had an audio-only remote option. We will continue to have the visual experience like we have today using Zoom and Teams or whatever platform is the current one of the day that the agency is using. But there will be both a physical and virtual space once the public health emergency is over. Not sure whether that will be in time for this board season or not, so we'll play it by ear. But once we are in a hybrid setting, board members will be able to attend in person or remotely at their discretion. And so, as will the public. So just wanted to highlight a little bit about where we are and as we keep moving forward, what the rules of the road will be for the public meetings here.
Thank you, Dave. Next slide, please. Finally, the last few pieces of legislation to bring up, and I would also agree that these are also having significant impacts on diversity, equity, inclusion, and in the health equity space. House Bill 1893, this authorizes emergency medical technicians to have expanded scope of services they're able to provide in moments where there's emergency crises, just kind of like a pandemic perhaps, allowing for EMTs to be able to provide vaccinations and be able to assist with certain duties during emergency times. 5508, this is increasing the availability of the state's insurance guarantee fund to a few different types of newer insurance type providers. 5518, this is the occupational licensure compact, authorizing the state to join the occupational licensure compact that is jointly done through multiple different states, allowing certified and licensed occupational therapists to practice within the state and also outside of the state with states that are also participating in the compact, allowing for greater access to occupational therapists, especially on the border parts of our state. 5539, this is educational service district funding. Just a few comments about this. This is a little bit of a different piece of legislation than what we would normally see as it pertains to PEB or SEP benefits. This legislation very simple in that it required the state to pay for the benefits for employees who are covered by a union within the educational service districts. The educational service districts were initially included in the 2020 launch of the PEB program. They're not school districts. They serve the school districts kind of on a regional basis. There's 9 ESDs. They're relatively small as far as the population size goes. They have about 3,500 employees total amongst the 9 ESD, about 100 of which are represented. When the ESDs lobbied for legislation prior to the launch of the PEB program, they were exempted out from participating in PEB until 2024, except for those employees who were represented because of collective bargaining. Those employees that they had that were represented did have to begin participating in the PEB program as of 2020. This legislation requires that the state provide full funding for those employees so their benefits are covered under the PEB program. It's only about 100 employees. It was just an interesting piece of legislation that did have a minor impact on the PEB program. That's why we bring it up. There was some legislation that had been put up by the ESDs to exempt them from participating in the PEB program and instead have them be mandatory participants in the PEB program starting in 2024. However, neither of those pieces of legislation moved forward, and we have not heard anything about them attempting to pass that legislation next year. It seems that they are going to go into the PEB program where they're going to find themselves going to the PEB program come 2024. And I think there's even been some conversation about whether or not they could speed that up or not. So that change will be happening. And there'll be, while the 7 of the 9 ESDs currently participate in PEB, they'll be transitioning over to PEB come 2024 as it stands right now. Last two, 5765 regarding midwives, expanding the scope of licensure for midwives, allowing certain devices and prescriptions to be provided by midwives. And 5793, there's another really interesting equity and inclusion legislation that provides for stipends to be made available to participants on state boards or commissions or other non-compensated positions that serve the state for individuals who are of a lower socioeconomic status or that whose participation may be creating a financial hardship on them. That there's now a stipend available to make sure that we can have a diverse population participating on our state boards and commissions and other non-compensated appointed entities that serve the state. So I think it's another really nice piece of equity legislation that was passed this last year to help improve the equity of our state boards and commissions, et cetera. With that, that is the end of the legislation for our session. As you can see, there really wasn't too much that had significant impacts on either the PEB or PEB programs. We appreciate all the good changes we have coming forward to enhance the benefits that we offer and that are offered throughout the state. There were a few reports that came out of the legislation. There was one report regarding the UMP, the third-party administrator that the legislature has requested in a budget proviso that the healthcare authority is to provide considerations about what it could look like to have some of or part of the third-party administrative functions returned to an in-house function. That report is due next June to the board. Before then it goes to the legislature. So that work has started. There's also a requirement, a proviso where the healthcare authority will work in tangent with the Office of the Insurance Commissioner to conduct a analysis on what a fertility benefit would look like that pertains to a sunrise review that was done by the Department of Health last year or 2 years ago. So we're just starting to kick that work off with the Office of the Insurance Commissioner to help to provide an analysis to the legislature of what a enhanced fertility benefit would look like as far as required coverage from insurance carriers. And lastly, there's a report where the PEB and PEB programs will be involved in pertaining to palliative care that will be spearheaded by the Medicaid side of the healthcare authority, but the information and data from the PEB and PEB programs will also be rolled into that as a overall report on palliative care for the legislature. And with that, I don't believe Tanya's on the agenda because of the last time she presented the overview of the budget she was able to provide at that time. So the only comment that I have on her behalf was that there was nothing further to review regarding the budget, which is good news. So with that, I'd be happy to take any questions or check in with Dave, make sure I'm not missing anything else that I needed to cover.
The only thing I'll add is that we don't have Tanya back because Tanya went over the budget the last board meeting and nothing changed from that presentation. So there was nothing new to report. So it's just Kate for bills today.
Great. Thank you, Chair and the board. And we'll be back next year with the next session. Work on that has already started. So thank you, everyone.
Thank you, Kate. It really is an ongoing process all the time. There's no rest for the weary. I think we should take a 5-minute break before we get into our next topic because it is the dental presentation and it will be a little longer than usual. So I think if everybody's okay, we will, I have that it is almost 10:30. So Dave will come back at 10:35.
Sounds great.
All right. Stretch those legs.
Ellen's here, so we're ready to start when you want to get started, Sue.
Okay. All right. We are going to move into our next agenda item, the 2024 Uniform Dental Plan Dental Design. Ellen Wolfhagen is our Senior Account Manager in the PEBB division, and she's back to share the specific proposals for benefit design enhancements and to start the prioritization discussion for possible changes as early as 2024. That's a little mind-blowing to think we're already creeping up on 2024. Her materials are behind tab 8. And Ellen, I'm going to turn it over to you for this presentation.
Thank you so much. Good morning, Chair Birch and members of the board. It's my pleasure to be here. Next slide, please. The objectives for today are to provide some follow-up from the March board meeting. And as Chair Birch said, present the specific proposals for enhancements to the UDP, have an initial prioritization discussion, and explain how that relates to the decision package process. Next slide, please. So in the follow-up to the March meeting, next slide, please. Tom McRobert asked about a comparison of the current dental portfolio. There's a couple of things that I'd like to point out. Managed care plans like Delta Care and Willamette are pretty similar to HMO plans. They have a fixed copay amount, but they have a very limited network. You can see only the dentists within their network. As you can see under the PPO plan, there's more flexibility. Are there any questions about this? Not hearing any. I'm going to move on. Next slide, please. Chair Birch asked us to do a comparison between Medicaid and the UDP. Next slide, please. So currently, Medicaid covers pediatric needs almost completely and basic adult needs. There are some age limitations, and many services are not covered at all. UDP covers a variety of services for all ages of patients. Dental coverage is optional under Medicaid, so the funding can fluctuate in periods of hard times. Dental coverage can be dropped. There are no member cost shares. UDP is state funded and there are member cost shares. And the provider networks and the rates that they're paid differ between UDP and Medicaid. Next slide, please.
Ellen, as you move on, I just wanted to highlight that we wanted to go over some of these compare and contrast on kind of a foundational elements of Medicaid versus the self-insured uniform dental plan, because as Ellen goes to the next couple of slides, if you just looked at the numbers on a chart, it doesn't tell the whole story. And so it is really important to think about these aspects as Ellen moves into the charts, that there are different pre-authorization requirements, age limitations. The definitions of class 1 and 2 and 3 aren't exactly aligned between the two portfolios. You know, as that funding fluctuates. There's cost shares in UDP, but not in Medicaid. So there's just a lot of different other components than a table on a page to keep in mind as Ellen goes into those tables. So that's why we wanted to lead with some context before just jumping into tables. So Ellen, with that, and hopefully people have enough of a disclaimer to be really thinking about that, let's go to the tables, Ellen.
Okay, great. Thanks, Dave. So here's the table that has some specific comparisons. And as Dave said, there are differences between what's included and what's not included. For example, in class 3 on Medicaid, posterior porcelain crowns are not covered. This is something that we're going to be discussing as we go forward. Next slide, please. Again, UDP covers things like bridges and implants, which are not covered at all under Medicaid. TMJ is covered, but not under Medicaid. And there's an age limit on orthodontia, which does not exist on UDP. So are there any questions about that comparison before we move on? Hearing none. Next slide, please. So this is just a reminder of the current UDP plan design. There's a deductible of $50 a person, up to $150 for a family. Class 1 is covered at 100%. Class 2, which is generally fillings, is 80%. Class 3, crowns, bridges, etc., is 50%. TMJ is covered at 70% with a $500 lifetime limit. And the annual plan payment is $1,750. As a reminder, the plan payment is different than how we look at medical expenses. On the medical side, it's a maximum out of pocket for the patient. On the dental side, it's the amount that the plan will pay towards services. Next slide, please. The options that we're looking for are presented here in order of the population impacts, the number of people that would benefit from the plan change. And they are the annual plan maximum adjustment, covering composite materials for fillings, providing an incentive plan that emphasizes preventive services, eliminating the deductible for children's benefits, and adjusting the TMJ lifetime benefit. Next slide, please. Just to give folks an overview, the total number of PEB members, this is members, so it includes subscribers and dependents, children up to age 15 is included because later when we talk about children's deductibles, age 15 is the cutoff point. Next slide, please. Now we're going to talk about the annual plan maximum. Next slide, please. So as I said, it's $1,750 annually. It's the amount that the plan pays. I do want to spend a minute going through a discussion of the premium and preferred providers. Preferred providers are those who have the best contract rate with Delta Dental, and the patient has the highest level of coverage with preferred providers and the lowest amount of copays. And the opposite is true on premium. Premium has a lower coverage rate, and there's generally a higher percentage that has to be picked up by the member. However, UDP does not prevent anybody from seeing a preferred provider. For example, the preventive services are covered at 100% for preferred providers. They're covered at 80% currently for premium providers. Class 2 fillings are covered at 80% for preferred providers and 70% for premium providers. So something to keep in mind as we go forward, you will see that the examples that I have and the coverage limits are the rates for preferred providers, but if necessary, I'll point out the difference. Next slide, please. While preventive services are covered at 100%, again, for preferred providers, they currently count towards the plan maximum. So that means that if somebody had a lot of expensive services at the beginning of the year, if they were going to continue with their preventive services for the rest of the year, they may not have support from the plan because they've used up their maximum. I just want to make a note that in PEB, about 4% of members exceeded the plan maximum. About 8 to 10% were within $250 of the plan maximum at the end of the year. Next slide, please. These preventive services, cleanings, exams, x-rays, periodontal maintenance, and fluoride application are the kinds of things that we're talking about when we talk about preventive services. They're currently covered at 100% in class 1. And again, that's the preferred rate. I'd like to walk through an example of how all of this could play out over the year. Next slide, please. Katie needs extensive work done in January. She has a series of appointments for x-rays and oral surgery. The total allowed amount of the bill is $3,500. The reason that I emphasized allowed amount is the dentist cannot charge balance billing for the difference between the allowed amount and the billed amount, although the patient will see the difference on the bill. And we have simplified some of the numbers here, so they're not exactly what a member might pay, but it will give you an idea of how this all works. In April, Katie returns for periodontal maintenance, which is also known as deep cleaning, and she must pay the full $200 allowed amount for that periodontal visit out of pocket. So let's walk through that. Next slide, please. Here's an example of Katie's claims. So her x-rays, the allowed amount is $100. It's class 1. UDP, the plan pays 100% of that. So the member paid 0. Let's talk about the oral surgery. So the $50 deductible per person, that applies for things like oral surgery. It also applies for class 2 services, fillings. So the $50 is applied at the top to reduce the $3,400 allowed amount to $33,500. The plan would pay half of that, which would be $1,675. But the plan has only $1,650 available, which is the remainder of the $1,750 less the $100 that they paid for x-rays. So they only ended up paying $1,650. The member is responsible for that extra $25 as well as their deductible. And so the member's out of pocket would be $1,750. In April, when Katie returns for periodontal maintenance, as you can see, she has to pay the full $200 because even though it's a class 1 service that's covered at 100%, there's nothing left in the plan maximum to reduce that payment. And so she has to cover the whole cost out of pocket. Next slide, please. The benefit change that we're talking about here is to remove preventive services from the annual plan max. We would continue the plan max at $1,750, but this would create an incentive for using preventive services, improve overall health by establishing good health routines, and improve health equity because it would equalize the treatment of dental preventive services and medical preventive services. As a reminder, under the medical plans, the patient pays neither a deductible nor do preventive services count against the maximum out of pocket for medical expenses. Next slide, please. So under the proposed change, this is what would happen. X-rays still covered at 100%, plan pays $100, member pays 0. For the oral surgery, again, the deductible would also apply. It reduces the $3,400 to $3,350. The plan would pay the full 50% of that, $1,675, and there's still $75 remaining of the plan maximum. The patient pays 50% plus the $50 deductible, or a total of $1,725. In April, when Katie returns for periodontal maintenance, the full $200 charge is covered at 100%, and the plan would pay, and the patient would pay 0. Next slide, please. So if you compared the out-of-pocket costs in the current plan design, the member pays $19.50. Under the proposed design, they would pay $17.25. And it's important to note that a patient having periodontal maintenance usually has 3 to 4 visits a year, and those at $200 to $300 add up rather quickly. It is unusual for somebody to have just preventive services use up their full plan maximum, but if you had a lot of periodontal maintenance, it might be a situation. Dave, do you want to add anything here?
Yeah, that the last part is what I was wanted to highlight a little bit is, periodontal maintenance might cost $500–600 a year. For your standard cleanings that are non-periodontal maintenance might be about $250 a year. No one is really getting to plan maximum, the $17.50 coverage, just on preventive services. But the idea here is there's a couple of fold, is to take away any potential perceived financial barrier to getting preventive services. We all know that health literacy in medical and dental and all of our benefits is always just something that's very challenging. And so going back to a point Ellen made earlier, trying to normalize and treat preventive services similar in dental as it is in medical, it's very much easier for messaging to be able to say, there is absolutely no cost associated with preventive services, and no matter how you slice it, rather than, well, you've gone for your preventive services, turns out you need to have several fillings, you might need a crown, and then you're eating into those services, and you almost feel penalized for going for your preventive service because you discovered all of these things, but your preventive service ate into your annual coverage. And so as you really start to kind of think about how people might delay care or forego care or time their care to the beginning or the end of the year, whenever their maximum is about to reboot, trying to eliminate some of those barriers and really just try to get people focused on good oral health and good oral health practices and not worrying about paying out of pocket for any of that is really kind of the hallmark here. And before we move on, I do want to say, I want to use this as an example for the rest of the benefit planks or options that Ellen's going to describe. There are many ways that each of these concepts could have been addressed. Annual plan maximum, could be raise the amount from $17.50 to $2,000 or a different number. All of them have different permutations. This one, the reason that we wanted to bring you very specific proposals on each of the ideas. We tried to focus on preventive services, and we tried to look at the overall cost and breadth of the population that would be impacted. And this one had the widest breadth, and also because it impacts anybody who has preventive services versus just the 4% that are near the top using their services. It allows more breadth across the population. And so, we'll get a little bit more into that, but I wanted to highlight, of course, there are other ways to address annual plan maximum, just as there are going to be other specific ideas that could come up for all of the other options that Ellen described. We really wanted to bring very specific proposals that we've vetted and started to get very specific financial pricing on. And as we get into the finance part, I'll bring some more of that up. I was going to turn it back over to Ellen, but I see Elliot has a question, so we'll pause for Elliot's question.
Yes, I appreciate this. So periodontal maintenance would be considered preventive care, would it not? So this ties in with the previous themes about equity. For older people, and I'm speaking out of experience, periodontal services affect usually people of a certain age. So you're looking at equity also for older people to take care of themselves. The other problem that I've heard is that there's some kind of connection with heart conditions, and maybe Ellen knows more about this, and healthcare. So again, this has a direct impact, or it can have an impact on older populations, at least probably more than young adults. And so you're looking at an equity feature in this proposal as well, I think.
Thank you, Elliot.
Also are impacting anybody who has just unfortunate teeth genetics. I say I'm a younger adult and I have unfortunate teeth genetics, and I have I've said it several times before in other meetings. I have periodontal maintenance and have for I don't even know how long. So it affects a wide range. You're correct, Elliot. It can impact older adults, especially for periodontal maintenance, as well as people who maybe didn't have as good oral hygiene habits at a younger age and are still kind of course correcting on their oral hygiene. And there's definitely a tie to overall health. Ellen?
Thank you. Elliot, absolutely, those are correct observations. And Dave, thank you for the explanation. So in the next slide, there's sort of a, next slide, please. There's a illustration here of the impacts. While 73,000 members of PEB were not seen at all in 2021, we hope that taking preventive services out of the plan maximum might encourage some of those people to go forth and have preventive services, which, as we've said, has overall health impacts. But the 239,000 people who did have those services would realize savings in terms of the plan maximum. So this really affects everybody within the PEB program. If there's no further questions on this, I'm going to move on to the next option. Okay, next slide, please. The next option is composite fillings. Next slide. So composite materials are different than amalgam. Amalgam is the metal material that's used for fillings. I just want to make a note that for anterior teeth, anything in front of the premolars, that composite fillings are routinely used and they're covered up to the allowed amount percentage. But for UDP currently, for posterior fillings, composite fillings are considered an elective procedure, and the coverage is limited to a percentage of the amalgam allowed amount. When we talk about network allowed amount, there's a different dollar limit for amalgam and composite, and I will explain this in more detail with an example. Next slide, please. So Joe requires a filling for a back molar. And we're going to assume here that the deductible has already been met, so I'm not going to go through that exercise. But the amalgam filling network allowed amount is $125. So under the current UDP, while Joe decides to go ahead with a composite filling, you'll see that what the plan pays is 80%. Remember, preferred provider class 2 is 80% coverage, 80% of the 125 PEB allowed amount. You'll also note on the slide that there's a difference in the network allowed amount, not in the PEB allowed amount. And that's where we are really driving this example. Next slide, please. So the proposed change would cover the composite fillings at, again, 80% of the network allowed amount. And coverage at class 2 for amalgam fillings would remain at 80%. Next slide, please. In terms of the number of people that took advantage of fillings, you'll see that the number of members is lower than the other numbers. That's because on average, people have about 1.6 fillings per visit. So the number of procedures, which are the bigger numbers below, is greater than the number of members. Are there any questions on this? Okay, we're going to move to the next slide, which
Sorry,
is
I do have one quick question. Going
Sure.
back to page 24, I'm still confused about the difference between the network allowed amount under the composite row versus the PEB allowed amount. Why is it different? Is there something, obviously there's something I don't understand.
So Elliot, the network allowed amount is what Delta allows all of the dentists in their network, the preferred provider network, to charge as the allowed amount. Through the contract negotiations, there's been a limit on the PEB allowed amount. So it's been limited to the same as what's covered for amalgam. Does that address your question?
So for example, if I have a non-preferred provider, the PEB allowed amount would be 125. Is that what?
No, if you
No.
even if you had a preferred provider under
Ah,
the PEB amount, you currently are limited to just a percentage of the 125. If you
thank
had,
you.
for example, Delta Dental through Boeing and you went to a preferred provider, if Boeing did
Okay.
not have a restriction, that preferred provider could charge $150. Does that
Okay.
explain the difference?
Yes, I had no idea. Thank you.
You're welcome.
And Elliot, before we move on again, this proposal that Ellen has presented on the next slide is specifically honed in on that bottom middle box. PEB allowed amount, composite filling, changing what we consider the allowed amount to be greater than the amalgam. And so that is the exact box that is being proposed as having a change, just to drive home the point.
Thank you for explaining this to me.
Thank you, Dave. Okay, can we move to slide 28, please? Okay, so just a reminder, these are the current coverage limits for preferred providers, 100% for preventive, 80% for fillings, and crowns at 50%. As we move forward into a description of the incentive plan, this will become more important. Next slide, please. So the concept is if you have a preventive visit in year one, it would increase the coverage for class 2 services in the following year. If you had no preventive visit in year one, it would decrease the coverage for class 2 visits in the following year. Just as a reminder, there were 239,000 people who did have a class 1 visit in 2021, but there were 73,000 members who did not. Next slide, please. Again, preventive services include all of these things, but let's move to the next slide. This is an illustration of how the incentive plan would work. So let's go through this a little bit. In year one, we're going to start everybody off at the current level, which is class 2 covered at 80%. I see Leanne has a question.
Thank you. I was just wondering, do we have the statistics to compare participation in the preventative services prior to the pandemic versus what's being provided of 2020? A lot of folks are impacted by the pandemic and choosing to delay care. It just seems to be a different incentive. So I just wanted to make sure that we're looking at the statistics of what that is.
Yes. $1,000 and setting an annual member benefit for $1,000. These limits are consistent with the industry standards. Next slide, please. Again, not a lot of people take advantage of TMJ, but there were 800 people in this pandemic year who saw a dentist for TMJ. Next slide, please. Now we're going to move into a discussion of prioritization. Next slide, please. So here are the impacts in the same order that I presented them, and it's based on population impacts. And as you can see, the excluding preventive visits from the annual plan maximum would affect the largest proportion of the population. Next slide, please. Here is the prioritization presented in terms of premium impacts. We are presenting information on the SEB program as well as the PEB program. A reminder that most SEB employees, when they retire, become PEB employees. You will notice that there's a difference between lines 3 and lines 4 for both programs. That has to do with the demographic difference in the populations under PEB and under SEB. Next slide, please. Just a reminder on the premiums who pays for employees, active coverage, it's 100% employer paid. Just a note on the decision package, even if in isolation a single change would not affect the funding rate, we have to prepare a decision package to go to the legislature because the cumulative effect of benefit changes could change the funding rate. Also, for retirees, COBRA, leave without pay, those members pay themselves, and therefore the premium impacts would be borne 100% by them. Next slide, please. So if we were to look at all 5 benefit proposals, the estimated per subscriber per month increase for each program would be between $5 and $7 per month. And a reminder, this is based on that pandemic period utilization. The actual premium increases may vary. And as a self-insured plan, ultimately the state has claims liability. And this is per subscriber, not per member. Dave, would you like to add some information here?
Yeah, I want to add a little context to the first bullet of what does $5 to $7 PSPM really mean? Well, kind of per the who pays the premium slide, if all 5 of these proposals, and we're not saying that all 5 of them would get funded, you know, this is all kind of the building process, and we see where the chips fall at the end of the day. But if all 5 of them, the range is $5 to $7, that means if all 5 of these were implemented, a retiree or a COBRA member or a leave without pay member would see monthly premium increases in that $5 to $7 range. And for the employer side of the equation, I like to kind of extrapolate what that means for an overall scope of a funding decision package. If $1 in the funding rate for each program is roughly $1.5 million. So if you take the $5 low end and the $7 high end and multiply each by $1.5 million, you get a range of $7.5 to $10.5 million. That's for a single program. You're very aware that we have 2 programs, PEB and SEB, and when we put forward decision packages in our modern era, we describe the effect of both programs. And it's my understanding that the governor and legislative budget folks very much think of if there's a change in one program, thinking of them at the same time. So double those numbers, and you get a decision package that's on the magnitude of $15 to $21 million. As a proxy, you'll remember that the agency put forward a decision package on long-term disability and potentially increasing the employer contribution to change that benefit in PEB from $240 to $1,500 a month. The magnitude of that decision package combined for the PEB and SEB programs was around $18–19 million. So this proposal of all 5 of these benefit designs is very similar to the scope and cost of like the LTD package. And so that's one thing, as you know, I dropped a breadcrumb I'm going to pick up from earlier in the presentation where I said there are many ways that each of these proposals could have been costed out at different ways to exactly put in the details of specific proposals. We were also trying to target something in the $5 to $7 range that would equal that kind of $15 to $20 million range for the overall decision package, because the experience is that after that, so it's really becomes particularly challenging to have a realistic discussion about that much of an investment at one time. And I don't want anyone to be disillusioned that there's any guarantee that the decision package would be picked up in whole or in part in its current state. But we were trying to balance kind of incremental realistic change, an emphasis on preventive services, looking at various equity lenses to come up with something. And I just wanted to give some context about what that $5 to $7 range looks like. I also want to say is, the decision paper that the agency will ultimately put together this summer, the plan is to, at this point, absent, something different coming up in both boards, because we're having simultaneous discussions with both boards, is to describe things focused on the impact to the breadth of the population, so similar to the order that's been presented here during this presentation, but then also to give include some language that talks about what we hear at both board meetings or from the stakeholder community about some sort of prioritization. That way, if the legislature and governor's office decide they want to, invest $3, then they can shop down the list while also knowing kind of the things that both boards felt should be more prioritized if everything couldn't be invested in at this time. So that's why we're kind of having a prioritization discussion, not asking at the end of the day for a formal vote from both boards. And in fact, there are various population reasons why there might be different parts of the portfolio of these options that would be considered more beneficial to one program over the other. And so really just interested at the end of the day as to what this board thinks for the populations you're serving might be the areas to invest in. And similarly, on the other end, if both boards were like, we don't like X proposal of the 5, if both boards think something shouldn't be on the table, then we take it out of the decision package writing process in its entirety. So if there's something that you deeply think shouldn't even be on the table, it'd be important to hear about that too. I see Elliot has a question. So Elliot?
Yes. What will help me when we prioritize, I can't speak for anyone else, of course, is Dave or anyone else, if you have an idea of what's most likely to pass, that will help me prioritize, because I may think something's important, but the legislature might eat it up because it'll get them votes. And I have no concept of what's a big vote getter.
Well, it's very hard to predict what 147 people think, or a majority of 147 people think, and it will depend a little bit on what the financial status of the budget projections are in the next biennial budget. We could have people who be like, yeah, we agree with all this in concept, and then there's no money. And then that kind of is the creature of poor timing. But that's one of the reasons, Elliot, that we've thought about anchoring the conversation in breadth of the populations that serve, because the more you can describe something as being broad-based or addressing specific equity issues, those seem to be particularly compelling points. And so, that it's we've tried to put together things that we think check those boxes at the same time. What would people want first? And we have a couple more slides that get into a little bit more detail. So Ellen, why don't you go through those?
Okay, next slide, please. So some insights on the TMJ and child deductible. If we combined those two benefit proposals, it would be under 50 cents per subscriber per month for SEB and under 25 cents per subscriber per month for the PEB program. So for the state and SEB organizations, obviously SEB organizations have to pay more into the SEB board. The budget impact is unlikely to change the funding rate at all for these two, and these two could be combined very easily, and we could move forward. In contrast, next slide, please. The next three options together are very expensive. Each of the three has an impact for each of PEB and SEB programs at between $1.25 and $2.25 per month per subscriber per month. So, any of these changes individually would impact the funding rate. So as Dave said, as we start to prepare the funding package and the relative prioritization, these will be factors that will be considered.
I'll just add a little bit that the first two, the child deductible and the TMJ being around a quarter for, or a little less, we're trying to give rough ranges because inevitably we'll refresh the numbers a little bit and we don't want people to get stuck on the pennies and nickels too early. But the final decision package will have very specific numbers, just to be clear about that. We wanted to give ranges for now. But the first two, the child deductible and TMJ, those are the sorts of things that, because they don't necessarily impact the funding rate, could just be language in the budget that says claims are assumed to be able to account for these expenditures and authorize those changes without even changing the funding rate. Some of you may remember a couple of years ago, that's exactly what happened with the only other change I'm aware of in recent history to UDP, where the change was from replacement crowns could occur every 5 years instead of every 7 years. It didn't require additional funding, but it was noted in the budget that there's an assumption that it is covered by the existing claims. That's something that could very easily be picked up because it very well may not, it could just fit within rounding of the budget because the funding rate is rounded to the closest dollar. And so those could be very easily picked up. And from a retiree out-of-pocket standpoint, think of that as like $2 a year, somewhere around $2.50 a year. That's going to come back to bite me, I know, because anytime I say a specific number, I hear about it for years. But a quarter times 12 months, you start to get that $2 to $2.50 range. You look at each of these three, the incentive, composite, and annual plan maximum. Remember that from a retiree standpoint, to make one of these changes, take these numbers and multiply it by 12 to think about the range of out-of-pocket expenses for a retiree related to each of these. And that's where I think there might be particular interest from this board to be very clear about maybe some preferences among these, because I'm positive based on the years of conversation during rate season and the medical rates and the focus of every dollar really does matter when you're on a fixed income. I'm eager to hear in the next couple of minutes some initial views and at the next meeting about the tolerance for all or a subset of these proposals, because they really will impact the retiree population directly because of the retirees directly pay the premiums in a way that no one in SEB feels and employees in PEB also don't feel. And I don't want anyone to be blindsided by that, so I try to be very transparent about it. So Ellen, why don't you tee up the questions and we can have a discussion.
Okay, great. Thank you, Dave. So next slide, please. So first of all, are there any of the proposed options that board members think should not be further evaluated? As Dave said, if the either board comes up with ideas that they think should be off the page altogether, they would be left out of the decision package. I see Scott has a question.
I was going to answer the question. Do you want me to? I'm sorry. So I'm very supportive of the non-deductible for children. The burden of childcare is most felt by those that are in the lower income. And we have a lot in the state of Washington where our average wage hovers around $70,000, although I'm sure Leanne can correct me. But given the demographics of the distribution of wealth, especially for those that may be on the lower end, I kind of see that as an equity issue of something that we need to do. Similar to the child care tax credit, where you're raising people up out of poverty, especially those that for people of color. This is a way to do that, and that's for children, and that they're not going to be sacrificed by difficult decisions their parents have to make on getting them access to care. And it's also in the same vein that I'm really struggling to support an incentive structure. With inflation, families are struggling with difficult decisions. Making a decision between going to the dentist or paying from the rent is real for some. And I think in the current environment, and as I talked about before, the disproportionate impact of being in a lower income, especially for people of color, I don't want those difficult decisions, which are real and big decisions that families have to make, to penalize them, to be penalized later. So I'm really recommending that we take the incentive off the table, and it's just not something that I can support. Obviously, I'll keep an open mind and I'll listen, but I'm really struggling, to be honest. You probably heard that a little bit in my conversations or my comments in the last board meeting when we were talking about the WEA plans. Thanks.
Thank you, Scott. Appreciate your comments. I see Tom next.
Yes, thank you, Dave. So I want to go back to the slide or page 44, funding for all 5 benefit proposals. So the overall estimated per person per month increase for each program is $5 to $7. Is that correct? Or is that for the total, were we to adopt all of them?
5 to 7 for PEB and 5 to 7 for SEB.
Oh, okay. Okay. So if we were to adopt all of them for, in this case, for the PEB, we could expect our monthly dues to go up approximately at the most, and I know you're ballparking this, but $7, is that correct?
Per month. So annually.
Yeah, per month.
Yep, per month. That's the ballpark.
Currently, I believe United Uniform Dental is $48 a month. So you're saying that could rise to $55 a month. Is that correct?
Yes.
Okay, and I know I've mentioned this before, but unlike other programs where costs have seemed to go up almost every year, I went back and looked at Uniform Dental going all the way back to when I retired, which was in 1999. And Uniform Medical Dental has not gone up every year. In fact, it has varied between a high of $49 and a low of $42, with the lowest point not being the year I retired. So I'm guessing that there are other external forces that affect the cost of dental care besides these kinds of programs. In other words, yes, this would raise it, but that doesn't necessarily guarantee that the next year those rates are going to be $7 more. It could be $5 more. It could be even $3 more, because there are other external factors that drive the costs of dental care based on the last 21 years of the increases or the decreases in dental care.
Yeah, a couple of things, Tom. These $5 to $7 estimates are based on projected utilization and assumptions of what utilization would change in the population with the change benefit. And that's kind of the importance of this last bullet. Ultimately, the state has claims liability as a self-insured plan because, we will have reasonable confidence in those utilization change estimates. But if they're off in either direction, you could have lower rates if the utilization doesn't change as much, or it could be higher if the utilization ends up being more than what's projected. So that there is that piece to keep in mind. And so that's one of the things that will ebb and flow. Also keep in mind that there's been part of the reason that there have been very stable rates over a multi-decade period is also because the benefit design hasn't had any substantial changes over a multi-decade period. And so, that if we had this discussion, 10 years ago, and there was some of these implemented, then rates would have gone up because the benefit change enhanced the benefit. And so the fact that there's been so much stability in benefit design has also helped reinforce stabilized rates. Another piece is utilization has been really steady. We have tried multiple ways to encourage and increase utilization of preventive services. And I think our data, the most success we've had is with Smart Health. and having additional focus through health literacy and points and encouraging preventive care. But it moved the needle, but there's still a lot of needle to move when it comes to accessing preventive services. So stability of the benefit design has also contributed to rates. And these $5 to $7 is also based on projected utilization assumptions, which they are assumptions that could be off in either direction, just like any assumption could be off in any direction. Just a couple things to keep in mind.
Yeah, I guess what I'm getting at is that even though we look at that and we automatically assume, oh my God, it's going to go up this much a month, it's not necessarily going to go that way because of the stability that we've had over the last 21 years. Excuse me. Anyway, that's how I would interpret that. So I think that's something to consider when we take a look at the benefit design packages that are in front of us. The stability of our dental costs are remarkable, especially when you compare it to our medical costs.
Elliot, do you have some thoughts? You were next.
Yes, I do have to premise my questions with the fact that I was staff attorney to the State Dental Board for 12 years. So that does affect a bit of my comments. I believe I agree with everything Tom said. And on top of that, I think it's short-sighted. Now, again, that's not going to help us with the legislature necessarily. Logic doesn't always work. But in the long run, you save money by people going in for the preventive work. It prevents them from getting more expensive work down the road, more composite fillings, more crowns, or even dentures. And I've seen that in my 12 years of working with the dental board, hearing expert testimony and being at hearings. It makes a big difference. So I think it's short-sighted. Okay, that's number one. Number two, I think the including the children is good too, because you're teaching children to have good patterns of getting dental care. And in the long run, it's going to save money down the road. And again, there's an equity issue here as well. I'm segueing back to equity for older persons as well. I've heard from many older people that they don't go in for preventive work because of the situation that's here, the way the benefits are designed. So they let their teeth rot and they get dentures. And I think for poorer folks, it's even worse. They tend to forego dental care. That's the thing that's easy to overlook until you've got a really big blown out problem. The last thing I'd point out with respect to the composites, and again, this is because of the work I've done, composites on baby teeth don't make sense. You're going to have to pull those molars anyway, unless they're permanent molars. Why would you put a composite in? The practice that I've seen over my years is that you put in a stainless steel crown. And also that helps poorer families. So it shows we're being reasonable. We're saying if it's a temporary molar, of course, stainless steel crown, amalgam, but a composite for permanent molar, yes, that's a different story. So based on my experience, composites on teeth that are going to be pulled out, that makes no sense. So you could save some cost on not putting composites on baby teeth.
Thank you, Ellie. Leanne?
Thank you. And I also just want to thank fellow board members for these really thoughtful discussions. I really want to echo what Scott said earlier. I think the incentive piece, while it may be something that is appropriate to continue to consider for future, I'm not comfortable with it at this time for the same reasons of children don't get to choose, it's parents or guardians who would be responsible for that. And incentives for marginalized communities many times ends up being more punitive than incentivized. So I'd like to suggest that you do a little more research on that piece of it and look at those impacts and come back at a future date.
Thank you, Leanne. Harry, you can round out and we'll have a full board, minus two so far, but Harry? And you're on mute.
There we go. Yeah, thank you. And thank you, Ellen, for putting this all together. Really appreciate the effort that's gone on into this. I want to answer the question that was asked. I'll get to that. But before I do, I just say, to me, our focus should be on cost containment. That's part of my role, or several of our roles. But while concurrently looking at ways to enhance the dental benefits for the broadest membership, and those things aren't always in sync with each other. But getting to the question, like others, well, I'll be stronger. I don't support the incentive concept for several reasons. To my knowledge, there's no documented study to demonstrate such a concept results in improved dental health or has a positive return on investment. While I respect Elliot's comments about, it makes sense. It seems sensible that if you have preventive checkups, that you'll have, less health care requirements down the road. I've not yet seen documentation that proves that. And I also think that it's just troublesome to me fundamentally that if a person is covered, does not have a premium share, does not has two visits covered at 100%, no charge, why they need to be incented. I just don't, fundamentally that is troublesome to me. Yet on the other hand, I wouldn't understand or can't support disincenting or disincentivizing, or in my view, punishing someone who, for whatever reason, it's not for us to judge, why they forego an annual checkup. So anyway, I feel pretty strongly about that, and I'm kind of hearing at least three voices that are not comfortable with that, and so I would propose that we not take this one any further. I also would like to say that I do have some concerns about eliminating the deductible for children. Now, I'm fully supportive of equity and all the other comments that have been made, but I think that to me, that's too segmented a group. And to me, it probably of less value to retirees who likely have older children. And so there's no benefit for many people, is limited or segmented, yet everybody gets to pay into it. So I think, in my view, I'm open to that being further considered, but I do have some concerns about it. So I'll leave my comments at that. Thanks for listening.
Harry. And I'm going to go back to you, Elliot. I did want to highlight one thing. There's a theme of preventive services, and I just don't want the concept of the focus of preventive services to only be on the incentive design. Remember that the annual plan maximum piece, removing preventive services from counting against that annual plan maximum, is also a concept of incentivizing and focusing on preventive services. The child deductible is also a piece that can relate to, I've lost my train of thought there. So I'm just going to go to Elliot.
In response to one of the members' comments, representing the older citizens and retired state employees, I can't do tech and talk at the same time. A lot of us older folks have grandkids. And we're more concerned about our grandkids than we were about our kids. So even if we have adult children, we're very focused on the care for our grandkids. So we do care. And some of us would gladly pay premiums, $7 a month to make sure our grandkids were covered.
Elliot, I had to chuckle because I remember there's a sub-board member who, when she came on the board, she announced, I pay $35 more a month to have a son-in-law. And her outcome of having, she was like, and I'm more than happy to have a son-in-law if it only costs me $30 a month. So I was like, well, that's good in the relationship. So I just thought of that and just wanted to share a little lighthearted comment there. Tom, you have some more?
Yes, I want to share when I retired. I had a lengthy conversation with my dentist, and one of the topics was heart health. And the preventative care that we mentioned and all of those different pieces that are covered are what we want people to be utilizing, because they will help with all kinds of things that you might not consider being part and parcel of what you do when you get your teeth cleaned. The periodontal work, all of those things are actually very important to the rest of your body as well. And it's one of the things I've actually made sure that I've taken care of over the last 21 years. So I think that the idea of incentivizing that for really, when you stop and consider what could be a relatively low cost benefit, I think we should continue to explore that.
Tom, thank you for those comments. I've been carefully listening, and I really, really commend this board for the robust conversation and input that we're giving staff, and for staff teeing up this notion. I would just say in general that I think, Dave, anything in the preventative arena should be brought forward for this board to continue to explore and investigate and to really consider, because I think we culturally have had such a disconnect from dental to our medical care, as Tom's last point was being made. And I think anything we can do to start creating that culture shift will get us towards better health and ultimately better health care, because we won't have that shift. Just like we're knowing that there's the kind of social to medical mix, this dental piece is a huge, huge part. So I don't have anything further to add this morning. I just really want to commend the board for the richness of the conversation. Dave, I hope this has helped you and Ellen as you come back to us with, I just so count on our team really living up to these principles that they're pushing on, and prevention is just so critical. And I think we really have to keep being a leader in this area to explore it. And I totally agree, Harry, there is a cost containment component of this, but Harry, I would also remind you that we have made some very bold shifts with our accountable care network and making primary care not fall under a deductible. And that is creating some wonderful incentive shifts too, with people getting preventative care. So with that, I'll turn it back to Ellen and Dave. Are there any other further comments from board members? I think Ellen and Dave. Oh, Harry.
Yeah. Thank you for letting me jump back in. Getting back on the incentive question, I guess to me, looking back at the chart that was shown earlier, it says that 73,000 or thereabout out of 312,000 members were not seen at all. So to me, it would be, why weren't they seen, and how do we incent them as opposed to incenting somebody that's already using it? That's, I guess, what I'm trying to understand.
Thank you.
I think that's the $1 million question. And I think I can't remember if I said this at the PEB board meeting or the sub-board meeting. Of all the benefit things in our programs, this is what I have struggled relating to. I love going to the dentist. I have no fear of dentistry. I never have. I go all the time, but I know that that is atypical. And some people just, and that's where I think a lot of the focus is maybe on that children piece and instilling good behavior and good experiences as a child can really help break maybe that cycle of that fear of dentistry. You know, I'm just irrationally afraid of snakes, and I can't explain it. And I know that people are irrationally afraid of dentistry, and there's always going to be some part of the population that's challenged with going. But anything that reduces barriers is kind of some of the hallmark here. I do want to call on the other couple of board members. I do want to say, as we are going to come back in May for additional discussion, and I hope at that time that board members can reflect over the next month, like if there's, several of you have highlighted, maybe this one comes off the table. I'd also really be interested in hearing at the next meeting, what do you think is the most important? If you had to have one thing and you know, and had a stand of like, this is the one we really definitely want if we can only have one thing, kind of to hear a little bit about that. The sub-board members are definitely ruminating a lot more. You've had a very robust discussion here. They seem to want to reserve their conversation for May. So I will be more than willing to share kind of the tenor of this board's comments with them. And then when they have their conversation in May, share the tenor of that conversation back with you. I will say the one thing that the sub-board asked for that we're preparing for them, they asked about a fixed plank. They asked about crown coverage. And if there was something that could be done to, and what the cost would be to increase the 50% coverage of crowns in class 3 to something else. I can tell you preliminarily that it's as expensive or more expensive than the combination of benefits put before you today. But we are looking at that because the sub-board in particular wanted to see that, knowing that pre-SEB, many school employees had crown coverage that was higher than 50%, even though 50% coverage is pretty standard in the market. So I just wanted you to know the flavor of what was happening in this SEB so far. And we have a line of more comments, starting with Elliot.
Yes, actually, I want to pick up on something Harry brought up, which was excellent. I would like numbers to back up the fact that when people go for preventive care, it's kind of like people saying, I don't need a vaccine, you know, I'm fine. When you go for preventive care, does it reduce the likelihood that you will have more expensive treatment down the road? And also, I know there are articles in this, what Tom pointed out, the link between heart disease and dental care, and the lack of people, if you don't go for an exam, how will they know that there's a problem with your heart before it gets worse? It's like saying, well, I won't go for a mammogram because there's no evidence that there's any link to my getting breast cancer and going for a mammogram. Well, it's preventive and they can diagnose it. So there must be stats on this somewhere. And I think Harry most adeptly asked for that.
So I am really appreciative of those comments, Elliot. And I remind everybody that staff is going to keep mining this and talking to other critical partners. I can see Ellen smiling like, yep, we've got some great work to keep doing. Let's try to get to our last two comments on this. And then we've got still many other agenda items to go. So Tom, I think, or I can't remember if it was Leanne first or Tom, but Tom, go ahead. Okay, Leanne, do you want to jump in?
Sure. So my comments were along that same vein. And I do agree. I think we all have a role in providing that education too, not just expecting that from the plan providers, right? So I think that that's something that it definitely has clicked with me of why we need to be doing that education and demonstrating, like what Elliot had mentioned, of those numbers of what does the prevention really mean and demonstrate the impact. And then I was also wondering from another previous comment about could we look at incentivizing in a positive, like in a reward way for preventative care versus it being the punishment way or what appears to be a punitive way. And then maybe from that, we'd be able to look at data that would pull us closer towards if there needed to be a disincentive versus an incentive. And I think of things like what we've seen, the impact of that little $25 Amazon gift card for people completing a survey and doing their smart health. I mean, again, I continue to take into consideration that, again, it may be COVID related and people are just like, I have to cut certain things out. And sadly, that's one of the things people have cut out is keeping up on their smart health. But that's wellness, right? And that's an investment and that's preventative. And so I do think that a lot of really important points have been made about why preventative is difficult for those who don't grasp it early on or have not had an opportunity to have that taught to them, because it does have an impact. And without that education, you don't know what that impact is until it's too late. So I would love for that to be considered of maybe we're looking at a reward incentive and then really looking at that as education and then being able to demonstrate how that preventative participation has had an even greater impact. And then from there kind of be okay, now everyone's gotten the education, we've changed that culture. Now, do we need to reevaluate and look at the possibility of a disincentive? It just seems like we may want to go with the reward first to ensure the education and the culture change is really taking root. Thank you.
All right, Tom, you're our last comment on the subject, and then we're going to move on.
Okay, well, it's actually not directly connected to the specific things we've been discussing, but going back to, I had a question that I was asked, and I really was unsure of the answer. Is uniform dental also referred to as Delta Dental?
So
there's Delta Care, Willamette, and then sometimes is Uniform Dental also been referred to as a Delta PPO?
Yes. So one of the names, if you will, is Delta PPO. If you are on the Delta Dental website and looking for a provider, you would look under Delta Dental PPO in order to find a preferred provider. But the name of the plan is Uniform Dental Plan, and it's different than Delta Care. And we're working hard with Delta to brand all of our communications appropriately so that people understand which things belong with which things.
The reason I bring it up is because someone I know thought they were signing up for Uniform Dental and they signed up for Delacare, and then the dentist that they wanted to see was not available to them, so now they have to wait a year. And they were fairly confused by the Delta being involved with both names, so I just thought I'd throw that one out there for whatever we can do to maybe make sure that people understand that they're not the same thing.
Thanks, Tom. We have received that comment, and we've been working for years to help Delta differentiate the different plans. Thank you.
Okay, thank you.
I can tell you, Tom, that we have seen improvement over time on confusion between the Delta Care and Uniform Dental as administered by Delta Dental plans. The volume of appeals related to plan confusion has definitely gotten smaller over the years, but it is a never-ending quest to continue to differentiate them for sure.
Okay, I'm going to call an end to Ellen's great presentation. So thank you, Ellen. We really need to move on because we've got other key ground to cover. Our next topic is the PEB modernization project updates. Chatrina Pitch, who is our PEB IT project director, is going to provide a status update on where we are with the PEB modernization project. Her materials are behind tab 9.
All right. Good morning, Chair Birch and members of the board. As Sue stated, my name is Chatrina. I am the PEB IT project director, and yes, definitely giving updates on the PEB modernization project. Next slide, please. So, an overview. What is the PEB modernization project? The purpose of the project will be to significantly enhance the PEB My Account online enrollment system. The modernized system will be used by subscribers, both employees, retirees, and continuation coverage subscribers, payroll and benefit staff, and the healthcare authority. Next slide. So the objectives of my presentation are to provide a real-time update on changes to the project. The first change is an increase to the scope, and the second is an extended timeline. While these decisions have been made at the high level, we're still working on essentially planning and working through the details within that phase with our project sponsors, internal and external stakeholders. Next slide. So the existing PEBMI account has very limited functionality and is used primarily by subscribers to make changes during open enrollment, to make their spousal and tobacco attestations and view current coverage. Payroll and benefit staff have access to really limited access around generating a statement of insurance on behalf of a subscriber or an employee and running just 2 reports. Pay1, our mainframe system, is currently utilized by payroll and benefits staff and HCA to enroll PEB subscribers and record all of the approved election changes throughout the year. The system communicates enrollments to our health plans and supplemental benefit carriers, produces monthly invoices, does automated member communications, and produces numerous reports. Next slide. So what's changed? So since the last that you have been briefed on this project, we had our Pay1 development team for our backend has 2 full-time developers for maintenance and operations. 1 position was recently vacated, and the remaining position will be vacated in spring due to a well-deserved retirement. Not having these 2 positions filled would have made end-to-end testing extremely difficult, and the Pay1 team would not have been able to maintain or support a new system. So, given that the Pay1 system is mainframe technology, HCA expects filling these 2 positions to be a long process and then several additional months for the employees to be trained and get up to speed. So our original time frame of going live in May was changed due to these extenuating factors. So next slide. Oh, excuse me, can we go back 1 slide? Thank you. So to the second point around COBOL, this is the programming language that comprises Pay1, and it's over 60 years old. Many of the COBOL developers have already retired from the workforce, and it has become increasingly difficult to find resources with the necessary skill set to support our system. So new programmers aren't interested in learning a programming language for essentially retiring mainframe systems. Now we can go to the next slide. So what's changed? Several options were considered by our steering committee prior to reaching these decisions. And after weighing several, we moved forward with the option that best leveraged our resources and aligned with strategic objectives. So the original scope was to provide an enrollment, a user-friendly enrollment platform to increase self-service functionality, to reduce reliance on paper forms and thereby reducing errors, and advanced tools for safeguarding our member data. The first decision noted under the increased scope came relatively quickly. Given the current staffing situation of the Pay1 team, we decided that being able to send enrollment files directly from the front end PEBMI account to carriers takes a good portion of the workload off of the Pay1 team. We further explored that benefit of reducing our reliance on Pay1 and found that it made the most sense to standardize how the enrollment and eligibility files are sent instead of having 2 different systems sending. Pay1 for SEB, the School Employee Benefits Board Program, and PEBMI account for PEB. So merging the 2 enrollment systems, PEB and SEB, under one platform simply makes sense and creates a single maintenance and operations team for both programs which will include front-end developers, business analysts, and testers. And this moves us into the right direction of reduced reliance on our COBOL developers. Next slide, please. So given an increase in the scope of this magnitude, a time shift was a given. So at this point, we're announcing spring of 2023 as our launch timeframe, and we will continue to share updates as soon as they are available. So our original launch was May of 2022. We are currently looking at spring of 2023, and of course, we need to complete some additional design and development work, and we'll be planning for user acceptance testing, end-to-end testing, and additionally, our final timeline is contingent on the hiring and training of the new Pay 1 maintenance and operations developers with that COBOL experience. Next slide, please. Really brings us to the end of our updates in this area. So what questions do we have? Quiet group.
They used all of their conversation on dental, Shatrina. It's fine. It's fine.
I was just saying
I really wanted to bring back to the board kind of the status and that we were expanding scope and thus changing the timeline, because when we last left off, I was excited to tell you that in May, a month from now, we would have options that weren't paper-based. And now we have an opportunity to expand some of the functionality and instead launch this next spring. So Scott, you have a question?
I do, and this is just something in my current job in technology. I'd be interested in a demonstration of the enhancement. I don't know if that's something offline I could ask for, but I'd be interested to see the capabilities and the functionality that is anticipated to be there once we go live, if possible.
I'd be happy to help provide that. So my contact information is here on the slide. Definitely, we can get together and I can provide you a demonstration of what we built so far.
Great, I see it right there, and I will write it down. Just don't change the slide for a couple seconds.
Great. And Dave, I was muted and I was jumping in saying everybody's teeth are sore and they just want to go brush their teeth after our dental conversation. So that's why Shatrina's not getting any questions. All right. I'm assuming, Scott, you have that written down, and if not, we can push that to you.
Yep.
Thank you, Shatrina, and we look forward to hearing back from you.
Thank you.
All right. It is time for our public comment. If there is anyone on Zoom that would like to provide comments, I'd like to first gather a list of speakers to effectively manage the time allowed for public comment. Would you please click on the virtual hand wave if you would like to speak, and we are watching. And I see Julie Salvi's hand is raised. Connie and team, do we have anybody else that has emailed, texted, chatted, waved?
Our list appears to be just Julie.
Okay, so at this point, I'd like to call Julie forward, and if you'll please identify yourself and who you are, your issue, and that'd be great. Thank you, Julie. Go ahead.
Great. Thank you for your time. I am Julie Salvi, representing the Washington Education Association. I enjoyed your discussion and debate on dental. I want to share just a little bit of insight from more of the SEB perspective. So K-12, as they're entering into this dental plan in SEB, had a very different experience prior to SEB, which I think you've heard about before. We have more members who are used to an incentive plan, and I don't know if there would be any data available that might be able to offer any insight of whether that had an effect on participation in preventive care, but would be willing to see what we could do if there was any data available. That system, though, as you may know, worked a little different, where it was both the preventive care and the other services that were incentivized. So I'm not sure if the data would be fully relevant. We do have members who were used to that system and would like to see that system again. And the other thing I hear about consistently from our members is the difference in the coverage for crowns. And that is one thing where we have raised up, there may be some equity concerns there. There's a difference of how we provide these benefit increases, whether we are giving a little bit of boost to a lot of people, or whether we are looking at some of those services that are very expensive and that can be sometimes out of reach for some of our lower paid workers. And so that's just a consideration I would throw in the room as you continue to have these discussions. Thanks for your time.
Thank you, Julie.
We also have Fred Yancey now as well.
Yes, I see Fred's hands up. Fred, go ahead and open up your mic and identify yourself, and the board welcomes your comments.
Thank you. This is Fred Yancey, and I'm talking today on behalf of Dr. Alan Burke, the Executive Director of School Retirees. He was unable to attend the meeting. He didn't say this, but I will. The move to allow preventative services not to count towards a plan maximum in dental, I would applaud immensely. I think that's a great approach. So, and I agree with Julie, being a retired school person. I'm familiar with the incentive system and took advantage of it, but I've always valued, I think I'm like Dave. I was born in a dental chair, and maybe he wasn't that, but that's what I feel like anyway for me. But anyway, Dr. Burke wanted me to remind the board that he has written a letter to the board and asked the PEB board to perhaps consider the development of a uniform plan that backs out the prescription coverage, and then consequently maybe offer some sole prescription coverage plans alone. His concern is, of course, the increased cost of a uniform for retired members, and so he had asked that perhaps the PEB staff or herb staff look at what that would be. The other thing he wanted to make sure is a large number of our older members are not internet friendly or internet savvy, and so I know he has said this, and I just want to reinforce the materials that come out, and avenue that come out of HCA need to be designed to be more senior friendly, whatever that means. Bigger print, more bullet points, less text, and less reliant on internet access. I count myself fortunate that I took typing in summer school in 8th grade, and that was just post Stone Tablet era, and so I'm computer savvy, but most of our seniors, our older members, are not, and they struggle with understanding what's going on and how to access all the great benefits that that PEB and offers. Thank you very much for your time, and thank you for all the work you do on this committee. And I too am sorry to see the loss of Ms. Tate. So that's it. Thank you very much.
Thank you, Fred. Okay, Dave and Connie, I'm not seeing any other signals from anybody. All right, a few issues of order. The next meeting will be May 12th from 9 to 2 p.m. So please, board members, mark your calendars. Members of the public, mark yours as well. And Dave, before we go into executive session, do you have any final comments that you would like to make, or any reminders about how we're transitioning on technology after we take a little break?
Just a preview of the main meeting. We'll have our third part of our dental discussion, and so I really implore board members to think about that question I posed of, if you could only, what is your priority? If you could, if you're the legislature in the governor's budget office and you only have $2 to spend, how would you spend it? We're also anticipating having a preliminary discussion about vision benefits, as the agency also is looking at possibly putting together a decision package for the next biennial budget related to vision benefits. We'll also have some presentations about some of the large upcoming procurements, even if they're not, some of them are related to functions that are under the agency's authority, but for their program procurements, and we'd like to keep the board informed. And we'll also continue our, from here on out, probably having an executive session. I do want to highlight is where, we'll ultimately take a brief break as we transition, and Jessica will move people into the executive session room. And if for some reason you're not getting pulled over and it's a few minutes after we've begun that process, please email or text Connie and Jessica, said something, and we'll be watching for you, and we'll reach out if we're not being able to pull you over. So you're going to read the executive session piece. I do want to call one quick attention to our agenda. On the second page of our agenda, we talk about what we're going to do in executive session. And there's a sentence that says no action as defined in RCW 4230-02 sub 3 will be taken in executive session. Really, we should probably be more nuanced and say no final action, because technically discussion is part of the action process. Final action means there's no votes, there's no decisions, final decisions or anything like that. So I just wanted to be a little bit clearer. We're going to pay more attention to that in future agenda pieces. And with that, Sue, if you could take us to executive session, that'd be great.
You bet. So pursuant to RCW 42.30.1101L, the board will now meet in executive session to consider proprietary or confidential non-published information related to the development, acquisition, or implementation of state-purchased healthcare services as provided in RCW 41.05.026. The executive session will conclude no later than 1:25. And again, board members, we're going to take 5 minutes. So it is 1:10. So at 1:15, we will be transitioned into our executive session, and we'll be returning to public meeting after that executive session to adjourn the meeting. There's not going to be any further presentations, just our discussion with no final action or no votes taken in executive session. So,
So I think you said 1:15, but really meant 12:15.
I'm sorry, I meant, yes. Yes, you're absolutely right. I meant 12:15. So take a 5-minute break, 12:16 now, and we'll be back together. Thanks all.